Can I invite the audience to stand as we sing together the national anthem? University President, Dr. Lincoln Edwards, Associate Provost and VP for Academic Affairs and University Administration, Drs. Nanibala Paul and Dr. Charlene Sharp, Dean, College of Natural and Applied Sciences, Allied Health and Nursing, Dr. Vincent Wright, Associate Dean, Dr. Erica Robinson Sturridge, other deans, Chair, Department of Nursing, Mrs. Juliet Poyser, other departmental chairs, administrators, faculty and staff, distinguished guests, healthcare colleagues, students, honored guests, good morning, whether you are in-house or online. It gives me great pleasure in welcoming you on behalf of the Department of Nursing to Nursing Symposium 2025, captioned Nursing Ethical Research, Harvesting Successful Life Ways. Like a beacon of light piercing through the complexities of patient care, nursing and healthcare research illuminates our path toward evidence-based practice. Today, we gather not merely as healthcare professionals, but as pioneers of patient-centered innovation, each carrying the flame of discovery that brightens the future of healthcare delivery. Welcome to this extraordinary confluence of minds, where, like the intricate systems of the human body working in harmony, our individual presentations converge to form a powerful body of nursing and healthcare knowledge. In this grand amphitheater of ideas, we stand at the crossroads of curiosity and discovery, where brilliant nursing and healthcare minds bloom like flowers in an intellectual garden. The presentations you will witness today represent not just countless hours of dedication, but the unwavering spirit of nursing and healthcare inquiry. Each presenter before you has embarked on a journey through the maze of methodology, emerging with insights that promise to reshape our understanding of the world. As we embark on this day-long odyssey of nursing and healthcare knowledge, sharing, remembering that every question asked, every methodology challenged, and every conclusion drawn adds another brick to the edifice of nursing and healthcare knowledge. Like stars in a constellation, each presentation will connect to form a bigger picture, illuminating the path for future generation of nursing researchers. Welcome to Nursing Symposium 2025.
Lead me, Lord, I will follow. Lead me, Lord, I will go. You have called me, I will answer. Lead me, Lord, I will go. Lead me, Lord, I will follow. Lead me, Lord, I will go. You have called me, I will answer. Lead me, Lord, I will go. Think about His love. Think about His goodness. Think about His grace that's brought us through. For as high as the heavens above, so great is the measure of our Father's love. Great is the measure of our Father's love. Think about His love. Think about His goodness. Think about His grace that's brought us through. For as high as the heavens above, so great is the measure of our Father's love. Great is the measure of our Father's love. Thanks, thanks, I give you thanks for all you have done. I am so blessed, my soul is at rest. Oh Lord, I give you thanks. Thanks, thanks, I give you thanks for all you have done. I am so blessed, my soul is at rest. Oh Lord, I give you thanks. Welcome, Holy Spirit. We are in your presence. Fill us with your power. Live inside of me. Welcome, Holy Spirit. your power live inside of me. You're the living water, ever-flowing fountain, comforter and counselor. Take complete control. Welcome, Holy Spirit. We are in your presence. Fill us with your power. Live inside of me.
The audience will remain standing as Miss Charise Drummond, junior nursing student, will take us through prayers.
Let us pray. Heavenly Father, we thank you so much for bringing us together for the Nursing Research Symposium. Lord, I pray that the implementation of this program will be a success and that we will learn vast amounts of information to increase our knowledge and to improve the nursing practice as nursing students and professionals. Continue to be with us and guide this program, dear Lord. In Jesus' name I pray. Amen.
At this juncture, Mr. Wesner Forrest, instructor, will take us through the spiritual emphasis, to be followed by remarks from Mrs. Juliet Poyser, Director of Nursing.
Good morning, brothers and sisters. You may sit down. Now we are going to meditate on the Lord's Word. We are going to travel a little bit using the book of Numbers, chapter 13 and chapter 14. And we have, for this little meditation, the title, which is One Group of Researchers Led by Two Different Spirits. As I said, the book of Numbers, chapter 13 and 14, display an investigation required by the first and the greatest researchers, and the goal was to explore the land of Canaan. And the Lord spoke to Moses, saying, "Send men to explore the land of Canaan from each tribe of their fathers. You shall send a man and a leader among them." So Moses sent them according to the command of the Lord. Therefore, to apply the pre-established methods of this exploratory invention required by the Lord, Moses selected one man of each tribe as a sampling method. However, even if this investigation was to explore and observe the land The book of Numbers, chapter 13, verses 18 and to 20, showed that a mixed method data collection was required because the investigators had to report what the land is like, whether the people are strong or weak, few or many, whether the land is good or bad, the city are like camps or strongholds, whether the land is rich or poor. And Moses told them, be good courage and bring some of the fruit of the land. After exploring the land, the investigators cut down a branch of one cluster of grapes, which represented the samples of fruit. They carried it between two of them on a pole. They also brought some of the pomegranates and figs. They returned from exploring the land after 40 days. They came back to Moses and Aaron and all the children of Israel to report to them and to show them the fruit of the land. They said, we went to the land where you sent us. It really flows with milk and honey, and this land is its fruit. Nevertheless, the people are strong. The cities are fortified and very large. Moreover, we saw the descendants of Enoch over there. While 10 of the investigators, under the devil's spirit, reported the findings with fear of what they saw, Caleb silenced the people before Moses and said, let us go up at once and take possession, for we are able to overcome it. But the men who had gone up with him said that, we are not able to go up against the people, for they are stronger than we. And they gave the children of Israel a bad report. Here, I would like you to pay attention there. They gave them a bad report of the land, saying the land and all the people whom we saw, and it are men of great size and very big and tall. You can imagine how fearful they were. And we like grasshoppers in our own sight. But Joshua and Caleb, who were among those men, tore their clothes and spoke to all the children of Israel, saying that the land we explored is an exceedingly good land. Now we can see Joshua and Caleb, they are under the God's Spirit. If the Lord delights in us, then he will bring us into this land and give it to us, a land which flows milk and honey. Only do not rebel against the Lord, and not fair to the people you saw over there, for they are our bread. Their protection has departed from them, and the Lord is with us. Do not fear. It's the same for us nowadays, our children of God. Sometimes we have things to do, and when we look at them with our eyes, we are fearful, and we say we cannot do it. At that time, we are influenced by the devil's spirit. However, when we are influenced by God's Spirit, we see everything is possible and we can do it. Now, Joshua and Caleb remind the people that Lord's command was to explore the land, and then He will surely give us the land because He promised to do so. How many times, even if we know we can do something, how many times we know there is something which is promised to us, and we refuse to be positive. And most of the time, we neglect to do it, and we miss a lot of things. Considering an abstract of this investigation, we need to recall that, according to the command of the Lord, Moses sent one group of 12 investigators to the land of Canaan. However, 10 of them were led by the devil's spirit that made them unfaithful, unconceived, unconvinced, skeptical, and fearful. Due to that, they perceived the severity of their failure or distraction, and then they gave Moses and the children of Israel a bad report to the land. However, Joshua and Caleb were sent among them as well, and they were under the Lord's Spirit. They became faithful, optimistic, honest, and ethical since they didn't depart from their gold, and they were under the God's Spirit. They perceived the benefits of going up to the land of Canaan and gave a good report to Moses and to the children of Israel. However, because of that, the 10 other investigators and the population, all the children of Israel, wanted to stone Joshua and Caleb. You can imagine sometimes you can be in a group working with, and we are together, but between of us we have different ideas, we are under different spirit, we are under different power. And then if we are under the God's Spirit and power, finally the victory will be for us. As a consequence, the 10 investigators who gave the bad report that was driven all the children of Israel to stand up against against Moses, Aaron, Joshua, and Caleb, and wanted to stone them, died in the wilderness without entering into the promised land. Most of the time, we can be assigned to do some things as a group. As we are divided by the bad spirit. Sometimes it is very difficult for you and I to reach our goal and be successful. When considering the context of today's event, the Nursing Symposium at the Northern Caribbean University, in which experts as well as student researchers come to share their accomplishments and research as a crucial application of this lesson from the Holy Scripture, implies acknowledging that the first researchers and the greatest one is the Lord. We come to this event where some of you, professional or students, are going to present your researches that you might take a long time to do. Bear in mind that they might be used as a source of scholarly literature that might serve to inspire decisions that will have considerable benefits and impact on human life. It is therefore crucial that the ethical aspect was integrated into the study so that it has reflected the reality of the population of the study. Otherwise, it might be harmful for human beings instead of making people harvesting successful life ways. Hence, whenever we conduct a study, we need to be led by the Lord's Spirit that will empower us to overcome the challenges to face and make us faithful and honest while conducting the entire and require and reporting the findings. So the Lord's Spirit led you, all researchers today, as you are here, student and professional, you are going to report. May the Lord's Spirit lead you all as Joshua and Caleb were led, in order that your presentations show the ethical aspect and the reliability of your research. And may they be used as evidence-based research to improve human lives. So may all of you have a productive annual Research Week 2025.
All right, before Mrs. Poyser comes, would like to thank Mr. Wessner for that very insightful spiritual treat. Thank you very much.
Thank you.
So, At this time, we will listen to the dulcet tones of our junior students as they bless our hearts with a special item.
Wonderful, merciful Savior, precious Redeemer and friend, who would have thought that a lamb could rescue the souls of men? Oh, you rescue the souls of men. Counselor, comforter, keeper, Spirit we long to embrace. You offer hope when our hearts have hopelessly lost our way. Oh, we've hopelessly lost our way. You are the one that we praise. You are the one we adore. You give the healing and grace our hearts always hunger for. Oh, our hearts always hunger for. Almighty, infinite Father, faithfully loving your own. Here in our weakness you find us, falling before your throne. Oh, we're falling before your throne. You are the one that we praise. You are the one we adore. You give the healing and grace our hearts always hunger for. Oh, our hearts always hunger for. You are the one that we praise. You are the one we adore. You give the healing and grace our hearts always hunger for. Oh, our hearts always hunger for.
Good morning, everyone. Thank you. Nice to see you. Can you hear me? Like I'm right on the, yeah, that's nice. So it's so nice to see you. It's nice to be here. I'm glad we're having this wonderful event. I want to thank Dr. Frankson for organizing it. I know he did a lot of work, and it's appreciated. So protocol already being established, I want to welcome you here today. I know that you guys have been having, you've been learning a lot, right? And it's been a challenge, and you're up for it. And I know that you will do well. And I just want to mention that our students will be going out to the clinical site for the second time. On Monday, they will be starting their clinical their clinical rotation. Those are the sophomores. And our freshmen are here, and our seniors and our juniors, and I want to welcome you and thank you for being here. Now, The theme of our research day today, nursing research, is nurturing ethical research, harvesting successful life ways. And I just want to emphasize how important research is. And the topics that we're covering, like I could talk about a lot of things, but let's talk about what we will be covering here. We will be talking about AI-driven simulation in nursing education, shaping ethical nursing practice, 2025 to 2035. That's a very interesting topic. We're going to learn a lot from Dr. McLean. The next topic is, and I'm mentioning these topics because I want to encourage those of us listening virtually to stay. You will be missing out if you leave early. The next one is artificial intelligence in nursing. Is this the future? And this is a very interesting topic, and I think you will be missing out if you don't come. It's a panel discussion, and we have our panelists here that will be talking about this topic. The next one is digital dementia, your attention please. I'm very curious. Ms. Miller will be presenting this topic. The next one, diet, lifestyle, cancer, health disparities. Is there a connection? Yeah, I want to know. The presenter is Carlos Casiano, Dr. Carlos Casiano. I look forward to that. The last one I have on here is a recipe for achieving mental wellness in unprecedented times, implications for patient care delivery. And this will be done by Dr. Frankson. So we really have some interesting topics here today, and I look forward to learning a lot. We know how important research is, and I think once we're here listening to these presentations, it'll kind of encourage us to do some more research so we can learn some more. At this time, I'm going to introduce the speaker. Our speaker is Marcia McAllister, Dr. McAllister. She was born and raised in Linden, Guyana, South America. I was in Linden. She is the firstborn of Alan and Donna McAllister and attended Mackenzie High School before enrolling in the nursing program at the former West Indies College, now Northern Caribbean University. She completed her Bachelor of Science degree in 1987, after which she immigrated to the United States. Dr. McAllister graduated from University of North Carolina, Greensboro, with her Master's of Science in Nursing Administration in 1998 and her PhD in Nursing Education from the University of Tennessee in Knoxville in 2020. So she was an underclassman of mine, because I graduated from NCU as well. Over 24 years of Dr. McAllister's career have been spent in direct patient care. Her clinical practice spanned a variety of medical, surgical, subspecialties, critical care, procedural, home health, and administration. So she's had a very varied career. Through her 37-plus years of nursing, she spent over 13 years in academia. She began her stint in academia as an assistant professor in nursing at Bowling Green Community College in 2005. After taking a brief hiatus, she returned to the classroom at Rowan State Community College in 2010, providing didactic and clinical instruction to associate degree in nursing, pre-licensure learners. After leaving Rowan State, Dr. McAllister was a clinical assistant professor in the College of Nursing at the University of Tennessee, Knoxville, where she was pardon me, I thought I could do it without my glasses. Where she was the lead coordinator for an undergraduate nursing leadership course in the Bachelor's of Science in Nursing program. She also facilitated learning through didactic and clinical instruction to junior, senior level learners in the same undergraduate program. Sorry. Her interests include online teaching and learning, focusing on the adult learner and how technology in nursing may impact knowledge and skill acquisition, and subsequently effective, efficient, and safe nursing practice. I think that's great. Some of her experience include low, mid, and high fidelity simulation, as well as work with simulated and real-time electronic health records. Though not currently in the classroom, she sees this, and we can help her with that. We can help her to get into the... You get where I'm going with that? Okay. We can get her in the classroom. This love is evident in her engagement in University of Tennessee, Knoxville Nursing Alumni Association mentorship program, and her current and future collaboration with NCU. So I'm glad she mentioned that. So her presentation, and she will repeat this, is entitled Recipe for Achieving Mental Wellness in Unprecedented Times, Implications for Patient Care Delivery. So I want you to give her an applaud before she begins, because it's nice to be encouraged. What do you think? Thank you.
Good morning, everyone. Good morning. Thank you. Ms. Poisser and I go way back. We stayed in the dorm together on the Kingston campus, and back then we did 1 year in Mandeville and 3 years in Kingston. And I must say, my heart is full, because when we graduated, my class of a long time ago, she mentioned it. I started nursing when I was 5, so don't try to calculate my age. But when we graduated, my class had 6 people in it. All right? And I'm looking around, and I teared up a little bit when the group was over there singing. But I'm so excited to be here. I had been away from campus for over 37 years until last November, when I came to the Alumni Association reunion, homecoming. Thank you. 100-year anniversary, homecoming. And I just had to come back. So here I am. I just want to thank Ms. Poisser for inviting me. I want to thank my family, my wonderful sons. My 2 sons are here with me. And my oldest one is not here. He's married and grown and have jobs and stuff. And my mom, who is back in Guyana right now visiting, and I think she's online. Thank you. Yeah. My mom is back home in Guyana, and I also have some other friends and families. Pamela Johnson, who is my batchmate. She invited me to come to homecoming last year. Thank you, Pam. I think she's watching online as well. I'm just thankful. I just want you to know that. Okay. I don't want to have like a major feedback, so I'm going to set this right. Okay. Maybe. I'll let you know. Okay, so the title of my presentation or our conversation today is Achieving Improved Patient Outcomes Through Evidence-Based Nursing Care. And you're going to keep hearing evidence-based nursing, nursing care, nursing outcomes. Those are all buzzwords that you'll hear throughout the day, throughout my discussion with you. And there's going to be a quiz afterwards, so you guys need to pay attention. And I'm serious, I'm not kidding. Okay. So the purpose of my presentation is to, can you hear me? Hello? Yes. Okay, the purpose of my presentation is to examine our roles as nurses in the research process, identify how conducting ethical research informs nursing practice and guides care, and how research impacts patient outcomes. So I want you to think of your journey of becoming a nurse. Some of you are still on that journey. As a matter of fact, most of you are still on that journey. Maybe you wanted to be a nurse since you were a child, or maybe you decided when you were in high school, or maybe nursing is just a second career, not just, nursing is a second career for you. Whatever your path, when we repeated the oath to devote myself to the welfare of those committed to my care, our focus was on providing hands-on, safe, competent care to those under our watch. I can speak for myself, and I'm sure I can speak for many others. When we decided to attend nursing school, research was not in our thoughts, not in our minds. The farthest thing from our minds, actually. Research was the thing that they did in the labs and didn't have much to do with us. Sometimes we hear about new ways of doing things in our work environment. We learn the new skill and keep caring for our patients the best we know how. Sometimes we incorporate the new ways into our practice, or we may be the baby boomers or the Gen Xers who feel that the way they have always done it has worked. So if it has worked, why change it? We may be resistant to change, but do we stop to ask, why are we making that change? What prompted the change? What is the science behind that change? What evidence do we have that informs or supports that change? Our primary goal as nurses is to provide safe, competent care for our patients. This involves providing care according to the evidence, according to the findings from research. We engage in evidence-based practice. Nursing has long been distinguished as an art and a science, the art of caring and the science of inquiry. Being built on such a foundation, nursing has been charged with using the nursing process. We swiftly gather data through assessment. Findings from the assessment and knowledge from scientific inquiry guide the nurse to identify the patient's presenting problems, which we refer to as the nursing diagnosis. You guys familiar with that word? Yes, you are, because you make care plans, right? Love them. Okay, which we refer to as the nursing diagnosis. The nurse then devises a plan, which is determined by the assessment findings and things that we have found, or evidence that we have found from research. With a plan in place, the nurse proceeds to implement or intervene on the patient's problems. The nurse determines the effectiveness of the intervention or the implementation by evaluating the patient's response and correlating it to the expected outcomes as evidence in research. The nurse must rely on the science. Plans of care must align with the evidence from research. As researchers, nurses are held to a high standard to uphold the integrity of the research process, since research informs and impacts nursing practice and ultimately patient outcomes. Paulett and Beck, who penned the world's most widely used nursing research books, define nursing research as a systematic inquiry designed to develop knowledge about issues of importance to nurses, including nursing practice, nursing education, and nursing administration. Bringing this principle closer home, I'd like you to pause for a moment and think of how you see nursing research fitting into your daily professional lives. How do you define your role as a nurse in nursing research? According to the National Institute of Health, the nurse wears several hats when it comes to research. In the United States of America, the NIH is part of the United States Department of Health and Human Services, which is the nation's medical research agency, making important discoveries that improve health and saves lives. Let's look at some of the... Yeah, the mic, please. Let me have the mic. This is off. Okay, we're back on? Thank you. Let's look at some of the roles the nurse play in the research process. Yep, we went a little bit faster. Okay, there we go. The research nurse recruits and screens subjects who meet study eligibility. And for consistency's sake, I'm going to refer to persons who are part of a research process as subjects. No disrespect. If you are the research nurse, you will engage in screening your subjects for the study. If you are the nurse at the bedside, you may be aware of a study that would be beneficial to your patient. If your patient meets the study criteria, and you let the research nurse know that your patient is a possible subject for that study. The research nurse obtains informed consent. If you are not the research nurse working directly with the subjects, I would advise you to leave the educating and informed consent acquisition to the research nurse, whose responsibility is to educate about the study, explain the risks and benefits, and obtain the informed consent. The nurse involved in research manages data through collection and documentation. Although you may not be the primary individual responsible for gathering data from subjects through interviews, physical assessments, observation, and specimen collection as needed, as the clinician at the bedside, you can ensure the required data is accurately collected and documented in the subject's records. I remember when I was collecting data for my research study, which was on sepsis, and of course this is going to come out throughout. I had to not use many charts because they had incomplete data, or some of the information I was trying to collect was not in the patient's chart. So that when we are documenting, please make sure that you are documenting everything that you've collected so that that information is there. In the event, someone can use that to help to promote nursing research and, of course, improve patient outcomes. The research nurse adheres to the study protocol. As a research nurse, it is important to follow the research protocol precisely to maintain data integrity and ensure reliability of the findings. Meaning, if the study is replicated under similar conditions, there should be consistency in the outcomes. The research nurse administers the study interventions. If you are the research nurse, and depending on the kind of study it is, you may be responsible for administering the study interventions. It may be performing a procedure differently from how it was done before. I remember several years ago, and for those of you listening online, if you've been a nurse for a while, you can relate to this. Working in critical care, we had to maintain hemodynamic lines. And so we had this pressure bag that we used to put heparin in. Now, heparin, as you know, is a blood thinner, right? And so what had happened, many patients developed what they call heparin-induced thrombocytopenia, which meant that they had some bleeding issues. And as a result of that, they had to find out another way of keeping those lines open. Research was done, and they realized, you know what, we can just use plain normal saline, put it on a pressure bag at 300 millimeters of mercury, and just have it connected to that line, and that maintained the patency of that line. It pushed like about 3 mils of saline through the line, and that maintained the patency of the line. The nurse engaging in research is responsible for subject monitoring and safety. Our ultimate responsibility is to maintain high-quality patient care. So as the nurse, you will be monitoring your patients and maintaining their safety. Monitoring for any potential adverse events and taking the appropriate actions. The nurse engaging in research collaborates with the research team and is a liaison between the subject and the research team. Another role of the research nurse is to keep the rest of the research team apprised of the subject's progress and any issues that may arise. The nurse translates the research. When implementing evidence-based interventions, the nurse is bridging the gap between research and practice, what we call bench to bedside. That is why we call it evidence-based practice or translational research. The nurse engaging in research is a patient advocate, according to Pullett and Beck. In this role, you will protect the rights and interests of your subjects, which are the patients. Did you give consent? Did the patient give consent for this procedure or for this research? Are they fully informed of the research process? Do they know what data will be collected and what procedures are involved? Do they know about the potential risks and benefits? Are there alternatives to the research that might be advantageous to the subject? Did the research team assure the subject that their privacy will be protected throughout the process and afterwards? Is the subject aware of their rights to withdraw after giving consent to the procedure or to the study? Does the subject have any contact information for the research team in the event that they have questions? The nurse engaging in research must think of the ethical aspects of the process, specifically focusing on protecting the rights of the subjects and ensuring their ethical standards and regulations are followed. The nurse must understand what is involved in the study to protect the research subjects, living and non-living. In the United States, and I can only speak for the United States, I have not done research in Jamaica or anywhere in the West Indies, so pardon my reference. In the United States, everyone who is planning to do or be a part of a research project that involves human subjects must complete the Collaborative Institutional Training Initiative, or the CD training. This training is completed prior to obtaining any permission from the Institutional Review Board, or the IRB, to conduct that study. How does ethical research inform nursing? How does ethical research inform nursing practice and guide patient care? During research, we must adhere to the ethical guidelines as set forth by institutions like the NIH, as I had mentioned before. According to an article published by a group of NIH clinical researchers last year, July, following the ethical guidelines enhances reliability and validity of our studies and protect the rights and dignity of the subjects and maintain high standards of scientific integrity. NIH identified 7 main principles that would help in conducting ethical research. We look at the social and clinical value of the study. Why are we conducting the study? What are we hoping to accomplish? Is it going to benefit anyone? What is the scientific validity? Is our research measuring what we intend for it to measure? Are we fairly selecting our subjects without bias? Are we handpicking them, or are we, because we know that there's a potential benefit for this study, or are we selecting them randomly once they have met the inclusion criteria for the study? What is the risk-benefit ratio? Are they favorable? Do the benefits outweigh the risk in the study? Remember, we promise to do no harm. So when conducting your research, we need to ensure the safety of our subjects. Was the study proposal independently reviewed? Was the study approved by the IRB, or in some cases the ethics committee? Because not every hospital has an institutional review board. These are important agencies that review the study proposal to ensure that the study protects the rights of the subjects and minimize any potential risks. Did the subjects agree to participate in the study? Was an informed consent signed? You are looking for willing participants who understand what they are getting involved in. You want an informed participant who makes the decision to participate of their own volition. Are we respecting the subjects? Are we protecting our subjects' privacy by maintaining their anonymity? Is identifiable information protected? During my study, the electronic patient health information, which I'll refer to as EPHI, for the subjects was always kept secured. No identifiable information was stored on any of my personal computers or laptops. All transmitted EPHI were coded, de-identified, entered in an Excel spreadsheet, and stored in OneDrive, which is an encrypted, HIPAA-compliant data collection repository. Documents were password protected and accessible to just me, my dissertation committee, and the IRB of record, which was the hospital. And we were bound to an oath to protect those files and information that was held in it, hence maintaining my subjects' anonymity and protecting their sensitive information. Let's go back to what I started earlier. think of what would prompt us to want to dig deeper, to find a better or more efficient way or safer way to do something when we're taking care of a patient. It may be an occurrence that rattled us, or something we think can be done in a more efficient way. Either way, we identify a problem and we want to find a solution that would lead to better patient outcomes, and our practice is based on science, and remember, the science works. Let me share a story with you. I had my head down with my nose to the grindstone as I went through my PhD program. Life was happening. Like raising twin young men in high school and coaxing another young man through college. You know, life. But my academic clock was ticking. Oh, sorry about that. My academic clock was ticking. As a matter of fact, it was actually gonging. I tried to figure out what I wanted to do for my research that would make a difference in nursing. I went through several iterations. Finally, my dissertation chair, Dr. Tammy Wyatt, advised me to attend a research council meeting at the local university hospital. That was where brilliant minds convened and shared ideas about how to improve patient outcomes through research. As advised, I spoke with one of the members who was a manager in the emergency department, and he was also the sepsis coordinator at the hospital. So I asked him, "What keeps you up at night?" His answer was enlightening and an opportunity for me to engage in research that I believed would be impactful. These are his words. "We have an increasing number of patients coming through the ED who are diagnosed with sepsis. Some of them die within 24 hours of admission, while some of them do not, even though both groups present with similar characteristics. How do we differentiate these patients and identify the ones most at risk of dying early?" You see, he had a hunch that there were similarities among the non-survivors. In nursing research, that hunch drives the curiosity to engage in research. We call that hunch or hypothesis. We investigate through research. As I began my literature search, both about sepsis and sepsis incidents, something surfaced that disturbed me and piqued my interest in researching this subject matter from a different angle. According to the sepsis experts, sepsis mortality disproportionately affects resource-limited settings. 5 years ago, the literature indicated that 85% of global sepsis occurs in resource-limited settings. Not much has changed since then. The NIH defined resource-limited settings as those where the capability to provide care for life-threatening illnesses is limited to basic critical care infrastructure, equipment, clinical skill sets, and available or accessible health care. Now this is hitting home. This means that places like here in Jamaica, in Guyana where I'm from, parts of Latin America, Southeast Asia, Sub-Sahara Africa, Oceania, and even some rural areas in the United States. When resources are limited, patient outcomes are adversely impacted. Any infection can progress to sepsis if left untreated. Delayed diagnosis of infectious disease leads to spread and prolonged exposure to pathogens, which initiate the sepsis sequelae and immune dysregulation, leading to poorer outcomes and higher mortality rates. So think of the things that we may encounter daily. Someone getting stuck with a nail, or a wound from a machete cut that does not heal, or a urinary tract infection that would not clear up, or a cold that develops into a pneumonia that is not adequately treated. Reasons for not addressing these issues may be multifaceted. The treatment may not be available or accessible to the patient, or the patient could not afford the treatment, or the patient does not have the means of getting to the doctor's office to get that condition treated. The point is, our communities are at greatest risk of being impacted by and dying from sepsis sequelae. I decided that my approach would be to identify simple biophysiological indicators that would detect the the patient at risk for early mortality when admitted with sepsis sequela. The indicators had to be easily accessible, rapidly measurable, and affordable, allowing for replicability across the resource availability spectrum. So I can identify indicators at my study site. So if I can identify indicators at my study site, I should be able to use the same indicators to detect the risk for early mortality among patients in places where resources are limited. So that was my hunch. My hypothesis statement that you see on the screen is what I came up with, the hypothesis statement and my research question. For context, patient cases were the subjects who did not survive beyond the 24-hour mark. Remember, when healthcare resources are limited, as I had mentioned before, complex or sophisticated diagnostic testing are not accessible. So whatever indicators I identified needed to be something that did not require complex and time-consuming testing or analysis, since time was of the essence. In sepsis, in sepsis language, time is organ. That means the longer a patient experiencing sepsis sequela is left untreated, the longer they go with poor tissue perfusion, and when they sustain more extensive organ damage and subsequent organ failure, their chance of survival precipitously diminishes. The challenge was to isolate predictors that were associated with early mortality. With that knowledge, we would ensure that those patients receive just as aggressive care, even if they're not coming through the door, as we refer to as crashing and burning. If you look at much of the research done on patients with sepsis, the emphasis is placed on identifying sophisticated markers like interleukin-6, tumor necrosis factor, alpha, procalcitonin, and those markers that you see on the screen. So my challenge was to find correlations between patient cases, characteristics, and the indicators that were easily and quickly analyzed in the resource-limited settings. So my research needed to be transferable. There's no one diagnostic test that helps to identify or determine the patient is experiencing sepsis sequela. Therefore, you must look at several things, starting with the patient's presenting signs and symptoms. To give you some context, the American College of Chest Physicians and the Society of Critical Care Medicine collaborated at a consensus conference in 1991 and discussed sepsis and its management. They developed the systemic inflammatory response syndrome, or the SIRS criteria, which stated the patient is experiencing sepsis sequela when they are suspected of having an infection and present with at least 2 of the 4 symptoms in the syndrome. So their temperature will either be over 38 degrees Celsius or less than 36. Their heart rate will be greater than 90. Their respiratory rate will be over 20. And their white blood cell count will be either over 12,000 or less than 4,000 cells per mil. Clinicians later realized that there were some limitations to using the SIRS criteria to identify the sepsis sequela, since there were several instances where the indicators may not be discriminatory for sepsis. For instance, a pregnant woman may have elevated heart rate or elevated temperature, which are common occurrences in pregnancy. A patient may be on medications like corticosteroids that can cause increased white blood cell count, or they may be on an immunosuppressant which can cause decreased white blood cell count. Sepsis is a life-threatening organ dysfunction in response to infection. According to Marick and Tabe, the sepsis specialist team met again in 2015 and identified another way of screening for the severity of sepsis sequela. They developed the sequential organ failure assessment, or the SOFA tool. I used the SOFA tool in my study, so the second research question and the second research statements are displayed here. Okay. So the higher the SOFA score, the graver the condition. When the statistical analyses were completed, the SOFA tool was predictive of increased risk of sepsis-associated mortality. According to Carballo and James, an increase in the SOFA score of 2 or more points is indicative of worsening organ dysfunction. SOFA should be completed on admission and every 24 hours. However, if your patients are dying in less than 24 hours, you don't want to wait until 24 hours to do that repeat lab. So you do your SOFA when the patient walks through the door, patient comes through the door, and then you repeat it like in about 6 hours. When you're calculating the SOFA, you're looking at examining 6 systems: the respiratory system, the hematologic, the hepatic, cardiovascular, neurologic, and the renal. If you do not have access or quick access to arterial blood gas, I'm not sure if you can see let me move to the next slide. Go back to this again. I told you about that. If you do not have access to arterial blood gas, from a study that was done, it was shown that you can actually use your pulse ox reading or your SpO2 reading in place of the PaO2, which is reported in the arterial blood gas. So to calculate the SOFA, you will just need to know the oxygen level that the patient is getting, which is FiO2, which is your pulse, and then your pulse ox reading, which is your SpO2. Find out the patient's platelet levels from the CBC, your bilirubin and creatinine levels from your CMP, Comprehensive Metabolic Panel, your mean arterial pressure, which I know most of you can calculate that, or most of you know how to calculate that, which you get from your blood pressure, which, of course, manual blood pressure would work, or your automated, depending on if you have a non-invasive blood pressure measurement, and your Glasgow Coma scale, which you do when you do your neurological assessment. I use the statistical significance of less than 0.05 in my study. So all organ system scores in the SOFA tool individually and collectively showed statistical significance in the risk of mortality where the p-values were less than 0.001. Organ failure is the main contributor to sepsis-associated mortality. My focus of study was identifying biophysiological indicators that detect patients at increased risk of mortality within 24 hours of admission through the ED. As you can see from the table that I showed you, that is up there, the indicators within SOFA are easily accessible, rapidly measurable, and affordable, and there's actually there's a tool that you can find online that you can plug those numbers in, and the machine is the calculator is going to spit out those numbers to tell you what the patient's SOFA score is. So that is so much easier. Body temperature was another indicator with statistical significance. We often get very attentive when a patient comes into the emergency room or come into you with a fever. But when someone comes with a low temperature, we're like, they don't have a fever. But those are the patients that are at highest risk of dying, because patients with a high SOFA score and a low temperature are actually at higher risk of dying than the patients that come in with a fever or patients that come in with a normal temperature. In a study reported in 2019, they found that patients were at greatest risk of sepsis-associated mortality when they developed infections in certain areas. Of the data they analyzed, 31% of the infections were in the lungs, 26.3% in the intra-abdominal area, 18.4% were due to urinary tract infections, 10.9% were soft tissue infections. There were similarities in my study. Identification of those indicators will assist clinicians in more efficient risk stratification and escalation of care, regardless of the setting. These findings have many implications for current nursing practice and future research. For instance, can we replicate this study with a local population to examine if SOFA is predictive of early patient mortality when they are admitted with sepsis sequela? Think of your patient being admitted with sepsis and how many of them have similar infectious sources. Might I have the mic, please? How many of them have similar infection sources to those identified in my study? How do we turn it on? So I'm going to tell you a story. And then I'm going to finish. I'm going to tell you a story. So Sandra was a wife and a mother. Most of all, she was a wonderful person. Let me go. She was a wonderful person. She was given a new lease on life because she was diagnosed with leukemia. And she went through chemotherapy. For those of you who have been exposed to taking care of patients with chemotherapy, you know how difficult that is, how grueling it is to the patient's body. So she went through her chemotherapy, she went through her bone marrow transplant, and life was good. She got a new lease on life. They remembered her and her husband going to a diner and having lunch, having a meal. After that evening, Sandra started developing nausea, vomiting, abdominal cramps, and she was having some loose bowel movements. As a result of that, she got dehydrated. So her husband decided, you know what, we're going to take you to the hospital because we can't do this. She's not able to keep anything down. Something that you need to know, at the hospital where I did my stint of working on the bone marrow unit, those nurses, that whole team, they're very protective of those patients. So when anything happens, the patient does not go through the emergency room. The patient goes straight to the unit. They have a room ready and the patient goes to the unit. So they call the bone marrow transplant unit and say, hey, told them what was going on, and they came in. So they came in. Sandra, because she had been immunosuppressed because of the medication that she was getting. You know, she had a bone marrow transplant. They're giving her the medication to not reject the transplant that she had, and that put her at greater risk of getting infections. So she, of course, developed that. So we would identify Sandra as a susceptible host in the infection cycle. So how do we know about the infection cycle? There was this gentleman called Ignaz Semmelweis, and he was a Hungarian obstetrician who is known as the father of infection control. And it started with hand washing, simple hand washing. See what happened? He made a connection between some medical students that would take part in autopsies one day and not wash their hands properly, and then help with deliveries the next day. And so once he identified that, he realized that, you know what, if we can keep a handle on this, then we can help with this infection issues that we have, because the patients were developing what we call puerperal sepsis and dying from it. So with that action, of course he went down on it, with that action, the puerperal sepsis decreased from 16% to 3% in his environment. Other names that you will hear that we talk about when it comes to infection control are Louis Pasteur, Joseph Lister, Florence Nightingale, and Robert Koch. But I still need to finish the story about Sandra. So we know that Sandra was a susceptible host, and she was admitted to the hospital with norovirus infection. If any of you know anything about norovirus, it is violent. It is an angry virus. It would clean your intestines out, not in a good way either. So we know that because of that, norovirus is highly contagious, right? And it quickly transmitted through food, water, and any surfaces which we refer to as the reservoirs in the chain of infection. Sandra and her husband, Charles, recall, as I told you, went to have lunch at the diner. So when they came into the hospital, the nurses sprang into action like ratatouille. They effortlessly settled the couple as they monitored Sandra's vital signs, inserted an IV and started IV fluids on her just to hydrate her, and administered medication for symptom management. Since norovirus is a virus, you don't usually treat viruses with antibiotics unless you know exactly there's something there's something else that's going on besides just a viral infection. So Sandra was in the hospital for at least 24 hours before I met her. She continued to have watery stools, but we thought she was turning the corner when her nausea seemed to have subsided and she was able to take clear liquids by mouth. Unfortunately, her blood pressure started to drop, and that started to happen right before my end of shift. Sandra would continue to have issues with her blood pressure during the night, and they will continue to give her more fluids throughout the night. According to the sepsis guidelines, and against evidence from research. Whenever you suspect sepsis, the patient is hypotensive, you start crystalloid fluids, like something like saline, to help with volume resuscitation. How do we know that? The gentleman by the name of Dr. Thomas Latta conducted a study in 1832 where he administered a solution of salt and water to patients suffering from cholera. If the patient does not respond to fluid satisfactorily, then we would want to add a vasopressor to the patient's regimen according to the sepsis protocol. Considering Sandra was being hydrated for at least 36 hours, adding a vasopressor at that point would have been justifiable and according to the sepsis protocol. It's not my word, that's from the science. The science dictated the actions. The science works. There's proof in the evidence. Sandra will continue to be fluid resuscitated another 12 hours overnight, that's after I had left, before the provider decided, much with the push of the nurse, to call a critical care team in. They called them in. The critical care team saw her. They're like, we have to take this woman to the ICU to better monitor her. They tanked her too much, and her body was overwhelmed with the fluid, which eventually left her circulation and went into the tissues around her circulation, what we call the extravascular space. When I get excited, I talk real fast, and then you can't hear me and understand what I'm saying. Okay, so it went into her extravascular space. First stop, it went to her lungs, causing her to develop acute respiratory distress syndrome, or ARDS. Sandra began working harder to breathe and to keep her oxygen saturation above 90, even with high flow oxygen. Fluids were shifting into her extremities, causing her ring to tighten on her finger. As soon as the team saw her, they decided, you know what? She needs to get to the ICU so we can manage her better. According to the research, during the sepsis sequela, the insulting microorganisms cause white blood cell to secrete what we call pro-inflammatory cytokines. And those pro-inflammatory cytokines cause vasodilation, which we know when you have vasodilation, what happens with the blood pressure? What happens with your blood pressure when you have vasodilation? It drops, right? So we see her blood pressure was dropping, so we have vasodilation, and then we also have the vessels are now becoming leaky. So we have fluid seeping out. Whatever fluid is in the circulation is now seeping out into the tissue, and you have vasodilation. So you have a double whammy. Blood pressure was dropping from those two things that were happening. Her inability to maintain her blood pressure even after fluid resuscitation signaled septic shock. Each intervention in sepsis management does not occur in a silo. They must be done interdependently to achieve maximum benefit, which is what you see on the monitor there. You see the patient, they give antibiotics if that's warranted. In her case, it wasn't. They identify what the source was. Well, we knew it was norovirus. They give her fluid, and then they also do vasoactive medication, which is something that helps to squeeze the blood vessels, to help to bring blood back to the heart, and that would help with circulation and perfuse your organs. Okay, for the nursing students present here, which is just about everyone here, give me some nursing diagnoses. I told you there was going to be a test. Say that what? Risk for infection, but she has an infection, right? But she's at risk for more infection. Got you. What else? Excessive fluid volume, yes. What you got? What'd you say? Excessive fluid volume. What else? I have anything over here? I know y'all did some nursing diagnoses on that stuff. So talk to me. What's that? Ineffective tissue perfusion. Something else here? I know y'all talk louder than that. Risk for decreased cardiac output. Yes. Yes. Thank you, Ms. Boycer. Great job, guys. Okay, so we have all those. So Sandra's situation is not an isolated one. We have many Sandras that we care for. doing things the way we've always done it because we're comfortable with our processes, not following the science. Sandra went to the ICU where they had to start her on a ventilator for respiratory support because remember she was having issues with her oxygen dropping, right? She had to go to the ICU for ICU for support, respiratory support. They had to put her on a vent. They had to give her vasopressors to help with that circulation, squeeze those blood vessels to get the blood back to the heart and out to circulation to the organs that are failing. And they also had to do what we call continuous renal replacement therapy, or CRRT, which is like dialysis, but slower pace of pulling that fluid off because she had too much fluid in her system. Because she experienced extensive organ damage, we lost her. Not on our floor, she went in the ICU. Of course, I followed up, asked them how she was doing. So remember, according to the Surviving Sepsis campaign, sepsis and septic shock are the leading causes of death worldwide. Sepsis disproportionately affects resource-limited settings where there may be limited resources to identify sepsis quickly and manage it effectively. Florence Nightingale, the pioneer of modern nursing, refers to nursing as an art and a science. Our practice is based on science. Nurses must be able to rely on the science, taking scientific findings from the bench to the bedside. Nurses are expected to use their current knowledge, be consumers of the latest research, and be participants in providing evidence to improving nursing practice and patient outcomes. Remember, research is not valuable to you unless it can be translated and applied. Remember, the science works, so we have to work it. Thank you.
Achieving improved patient outcomes through evidence-based nursing care. 3 key themes emerged from Dr. McAllister's presentation. 1, evidence-based practice integration. 2, patient outcome optimization. And 3, research application in clinical settings. Thank you, Dr. McAllister. At this time, we'll entertain 5 minutes of questions for Dr. McAllister. Questions for Dr. McAllister? Okay. Then we will move right along. We will invite Mrs. Carol Stewartson, BLS instructor and faculty in the Department of Nursing, to give our appreciation to Dr. McAllister for her presentation.
Can we have a round of applause for Dr. McAllister and her presentation? Well said, Mr. Williams. Today, we have had the privilege of a true nursing leader, haven't we? She have displayed this. Dr. McAllister, you have showed dedication, passion for evidence-based nursing and for your profession. For this, you have reminded us as well that healthcare outcomes are critical when we pay attention to certain information and also the observations that we have made in our practice. You have spanned a wide career. You have done direct patient care. You have done academia. You have mastered. And you have also gone into research, evidenced by what we saw here today. So, you have contributed to this wonderful profession. Also, we want to say thank you because you have inspired us to continue learning, to continue questioning, and to improve the way that we do patient care. True?
Yes, ma'am.
Yes. She has also traveled a long way to us. And for this, we're thankful that she has joined us here today. We are privileged. And also her son, right?
Yes.
Okay, can we...
They're right back there.
Okay. Oh, nice to meet you, sons. Okay. You got it, that support.
Yes.
And so on behalf of Northern Caribbean University, and by extension, the Department of Nursing, we want to express our gratitude to you by your invaluable insights and the time that you have spent with us. We give you this little gift as a token of our appreciation. Thank you very much, Dr. McAllister.
Thank you. Thank you. It's not going to be an Oscar speech. I appreciate you guys. Proud of you all. You can do it. I know it's hard, but you can do it. And you make NCU, West Indies College, make the best nurses out there. Sorry guys online, but we do. Keep up the reputation. Make the profession proud.
It would be remiss of us to be having a research symposium and not have greetings from the department responsible for research. So at this time, I'm going to invite Dr. Morton Frankson, Director of Research and Statistics here at NCU, to kindly bring greetings.
I had to fight the temptation to do the moonwalk. Okay, didn't fight it hard enough. Hello everybody, greetings. I would just like to say to our Dean for your college, Dr. Vincent Wright, Professor Vincent Wright. I appreciate working with your college, sir. About a year and a half ago, he wrote me an urgent letter when I just got this job, saying that I should report to teach nursing research. And since I knew him from before and he was a man of seriousness, I just saluted and went to work. I didn't even ask how much richer it would make me. But it made me so much richer, knowing those of you who I have known and taught research to you. So, thank you, Dr. Wright, for this wonderful college that you are supervising. And then I met the director for nursing, and we just fell in love. That's all I'll have to tell you. We fell in love. She's such a cool operator. And we just worked beautifully after that. I even got in trouble. She got me to teach pathophysiology. And that made me a better man. I hope you guys made you better people too. Remember the promise? Since you all got such great grades, you got to keep reading pathophysiology for the rest of your lives. And one of you come back and teach it, okay? Okay, good. And I would like to just recognize the fact that from yesterday, from yesterday was what, Tuesday? From Monday, I've met an amazing gentleman, Professor Carlos Casiano, and we've just been two young men hanging out, having fun. It's been wonderful. He and my wife are from Puerto Rico, and it's just been wonderful. So, greetings to all of you. I'm the Director for Research and Statistics for this university. And for some of you, I'm also the campus physician and have had the privilege of taking care of you wellness-wise. Really, what we have been trying to do is to, in the most wholesome and healthy and joyous way, in honor and glory to God, promote excellence amidst us all. Our God is the God of excellence. Ellen G. White says, excellence is knowledge we derive from experiment. Taste and see that the Lord is good, she said. Some, yes, a large number have a theoretical knowledge. They have never tasted and learned by experience that the Lord is good. Testimonies to the Churches, Volume 5, page 221. And in Volume 2, page 593, she goes on to say, rejoice in the Lord always, says the apostle. Let it be your object to make those around you better. And I would add regarding research and seeking, especially as she continues, riches which are imperishable. I hope you got that. I hope you got that. Because noble research is an ethical quest towards such excellence. It is truly a mission-driven endeavor along a pathway which we in academia, among other settings, deliberately walk habitually, even systematically at times, whether a qualitative or quantitative approach is elected, with clarity of purpose, determined to throw light on some issues of uncertainty. Those of you who have done research with me knows that we don't do research on things of which we are certain about. The literature is strong. We use it to take care of people. But if there's uncertainty, equipoise, then we can do research ethically. So congratulations. I gave congratulations to the entire college yesterday, so I'll specifically say to the Penn School of Nursing, of which you all belong and which we love so dearly. This is an awesome aspect of Northern Caribbean University because of you faculty, other workers, and students. We love what you do. We love the fact that at first you start out don't knowing what to do, and then after a little bit of encounter with us, a few weeks, months, etc., years even, you finally think you know what to do. So life will teach you where we failed to, but we're glad that we've been able to guide you. I'm not only saying thanks to the college, but I'm also saying thanks to the person that I report to, Dr. Nonibala Paul, the Associate Provost for Academic Affairs, to our president, my longtime, and Dr. Casiano's longtime friend, who commissioned me to come here, and with no regrets on either end, I hope. And these folks have been supporting us, so we must mention them. They have been supporting us so that we can carry out these kinds of programs that I hope you are being edified by. By the way, I hope that you have been, I've seen some of you, so I know this is true. I hope you have been going to the seminars, the conferences for some of the other colleges as well. I didn't see some of you last week, Thursday, so many of you, but I saw you from Monday starting to turn up to some of the other things with the College of Humanities and Behavioral and Social Sciences. I saw you doing that, and I saw you yesterday in the Science Symposium, some of you. Let me let you understand that it is a policy of the university that if you see a particular lecture on any day that you want to go to during research week, You just communicate it to your teacher, your instructor. Your teacher cannot mark you absent. You come to the lecture, you enjoy it, you grow with it. That's part of university education. We used to be West Indies College. We're past college behavior now, and we're into university behavior. Right? College was great. University is universally great. So, I want to just say that it has been wonderful to have the support of all of these folks in helping us. I'm here also representing Professor Giles for graduate studies, and nursing does not have a graduate studies program yet, but after today's lecture, I know a graduate studies program is coming soon. So, I'm putting the two of you on that mission over there. Make graduate studies happen, and then you will see Professor Giles down here as well. And that's for years to come, because it is, you don't just stop at a bachelor's. It used to be, when I knew the Big Six, it was a big thing to have a bachelor's. The first bachelor's program in the entire Caribbean was right here, the Big Six. I know them, my personal friends. And everybody now has a bachelor's in nursing, almost. More than they even just have RNs. Do people stop at RNs anymore? Maybe. But you notice what that's going to mean? You're going to have to raise the game, because everybody's resume says bachelor's in nursing, so you're going to move up to master's so that you can get that job over the next person, which is rightly yours, especially the promotions that come along the way. So I want to express my thanks to you from Professor Giles in anticipation of that bachelor's program and that master's program and the doctorate program, yes. I want to also say thanks to God, because He's just been loving us. He has just been, as Jeremiah 29:11 says, filling us with hope for us and everything, and supporting us so that, you know, we can have a wonderful future. And we want to claim that promise in our lives for successful lifeways. So greetings to all of you who have joined here in this program today. And we want to let you know that this is a very important conference. We're not just doing this to check off something important that the university does that you have no connection with. I really think that as you go through today, with all that you have learned, whether you're first year or second year, you're going to find things that you can add to what you have learned that will make what you have studied clearer. It will give it more purpose, and you will actually see some things even that you might want to research one of these days. And if that is what you are going to experience, God bless you. We have gone through from Thursday of last week the symposium called Religion and Theology, Monday, Business and Management and Hubs. Tuesday, yesterday, was a Science Symposium along with a nutrition emphasis. And by the way, later on today, around 1 o'clock nutrition department is bringing some special drinks for us that they want you to try out. So you should have gotten it from yesterday, but it wasn't ready. So they went and they experimented on it. Sorry, they mixed it properly. And they are bringing it now for you. You have to taste it. I'm sorry if you didn't come to the wonderful food fest that was here yesterday. But continue to attend today and make sure that you, as much as possible, attend, even virtually, but especially in person. Tomorrow's by the College of Education and Leadership, and the morning through till midday, and then after that will be the closing exercise. We want the closing exercise to be packed house, upstairs and everywhere. Please come out at our chapel at 2 o'clock, and swell the numbers. None of these things, not even in my classes, do I force you to attend. You're adults. Please exercise good judgment and turn out because you saw the importance of it. So, I just would like to say how much I appreciate all of you and how much I want to say, as you endeavor to attend as many of these research-related presentations that will be given, I wish for you all abundant, enhanced success in all aspects of your life. Thank you.
At this juncture, we'll be having a break, and while you're on the break, you can view the exhibits that are on both sides. And we'll come back for section 2 in about 20 minutes. Let us all reassemble for section 2. Section 2, the technological and innovation section, AI and digital focus. That's what we're going to be looking at in section 2. Our first presentation is entitled AI-Driven Simulation in Nursing Education. Our presenter will be Dr. Nikki McLean. Dr. McLean is a trailblazer in simulation education and innovation. She is not merely a leader, she is a beacon of innovation in the ever-evolving world of simulation education. As the esteemed Director of Simulation and Innovation at Northern Caribbean University and Assistant Professor at the College of Natural and Applied Sciences, Allied Health and Nursing, her influence knows no bound. Fueled by an unwavering passion to revolutionize healthcare education, Dr. McLean has ushered in transformative initiatives that redefine the landscape of simulation education and professional development. Her visionary mindset has birthed avant-garde curricula, orchestrated immersive training experiences, and delivered groundbreaking programs that challenge the status quo of traditional learning. With a wealth of experience dating back to 2007, Dr. McLean stands at the vanguard of simulation in healthcare. She has played a pivotal role in developing and launching state-of-the-art simulation facilities, showcasing her commitment to excellence. Her expertise encompasses the strategic development, implementation, and evaluation of a diverse array of simulation programs tailored for various environments to include higher education, clinical practice, military settings, and international organizations. As a certified healthcare educator, Dr. McLean infuses her role with a rich tapestry of knowledge and insight. She not only commands respect as an instructor in medical and nursing education, but also excels as a facilitator of interprofessional education groups, nurturing collaboration and innovation across several disciplines. Beyond her academic and instrumental contributions, Dr. McLean is a trailblazer shaping the future of simulation education. She is actively involved in simulation certification reviews and collaborates with prestigious organizations such as the Society for Simulation in Healthcare. Her expertise enriches international healthcare task forces and work groups, further solidifying her impact on a global scale. As a true innovator, Dr. McLean's talents reach far beyond education. She is a skilled grant and proposal writer, a certified Team Steps master trainer, and a passionate Stop the Bleed instructor and ambassador. Through her advocacy, she empowers individuals to rise to the occasion in emergency situations, making a profound difference in the lives of others. Ladies and gentlemen, help me to welcome Dr. Nikki McLean.
Good morning, everyone. All right, it's a pleasure to be here. Just to briefly speak about simulation, more specifically about AI. So we would have started our simulation program officially, the official simulation, because I always like to have the caveat that simulation has always been around. It's always been a part of nursing education, but the formalized integration in our curriculum, throughout our curriculum, has been about 4 years. And so with that, we have grown. We're still collecting data. If you've been at the other symposiums in the past, we're collecting data still on the integration of simulation in a bachelor's program in the Caribbean. And hopefully we'll be able to publish in the next year or so. So that is the goal. But today, I want to take just a different slice out of the watermelon, so to speak, and talk a little bit about AI, because we know that that is not so much the wave of the future, it's the now. It's been, and it continues to be. So I want to share just a little bit about just a brief literature research that I did, or lit search actually, and then put it together just in an abstract, because we're hoping to eventually have that be a part of further research that we do as it pertains to simulation. So, As far as AI is concerned, UNESCO, and I'm sure we're familiar with UN and all the groups that are there, but these guys are the specific keepers of education globally. They found that the term artificial intelligence, otherwise known as AI, was first used in 1956. So that's how far back AI or artificial intelligence was being discussed. And this actually was described under the auspices of science and engineering, where they were looking to make intelligent machines. So you would hear the word machine learning, which has to do with how we communicate with machines and how we teach them to learn. And so really we have been the starters or the initiators of this whole explosion, if you may, of the growth in AI. Recently, as far as private equity and venture capital funding, because I do have that business background, so I can't help but bring that in. AI companies have actually increased nearly 5-fold in their activities and their implementation of AI. So in 2015, they were at $16 million. And today, actually, as of 2022, they were at $79 billion as far as the investment and the activities that they do in AI. So that just kind of gives you an idea. But I want to take AI and pull it to our level within NCU. The thing that I think is so important is the alignment of our ethos, the alignment of our mission. And in looking at the literature and seeing what's there, I see how what we would want to do with AI and simulation, how closely it aligns with NCU's commitment to innovation in healthcare. Because it's all about the best practice. You heard that mentioned earlier. And really, it's about theory and practice. So what you're learning in the classroom, how do we take that to the bedside? And you hear me say that all the time when I'm teaching. What you're learning, it's great that you're learning, it's great that you're getting good grades, but how do you take that to the bedside and impact care at the bedside for your patients? So that's kind of the focus in what I want to take. So with AI in business, growing as much as it has been, there's also a rapid evolving nature of AI in nursing education. So it's no longer a concept, it's no longer futuristic. And so it's projected that by 2030, we will have about 78% of nursing programs using AI, and more specifically using emotion recognition AI. I don't know how familiar you are with that. I know some of you students are way ahead on this AI stuff. And it's not just ChatGPT, okay? Just to be clear. But the emotion recognition is geared toward communication and how you communicate with patients, how you communicate with families, how you communicate with each other. And so a 78% level of interacting in such a way where you're not in the hospital yet. You're right in the lab and you're integrating this emotion recognition. You know, what does that look like? Ethics, what does that look like? And we're going to talk about that a little bit. So imagine that you're interacting with a virtual patient, students, whose facial expression and tone adapt in real time. You know, that takes you to a whole different level mentally. And you can't help but immerse yourself in the experience. Because after a while, you will forget that you're in the lab doing simulation. And that's the whole idea. We want to increase the level of fidelity and realism when you interact in the lab. So you can think about the competency-based learning and the future and what that holds. So you heard us talk about the 2025 to 2035, window. That's just really arbitrary, because when I looked at the literature, It's already here. Like, we're in 2025, and there's a lot that they have predicted for that interval of time that has already happened. And there's more happening as we speak. So there's more that has happened since I put this PowerPoint together to talk about it. So just so you know and have an appreciation, you hear about the 2030 goal, the sustainable development goal as far as growth and all of that. The education is top priority for UNESCO. Does anybody know what sustainable development goal is covered in education or covers education? How many are listed? How many goals are listed? Very good, because you had principles of health promotion. So I would have hoped that you knew that. 17. What's for education? Anybody know? You could have looked that up in the time that I asked, using AI, leveraging AI. It's number 4. And what UNESCO believes, and they have said this, and there is a publication on this, is that AI has the potential to address some of the, get this, biggest challenges in education today. And when I talk about biggest challenges, one of the ones that come to mind, and of course having moved back here from North America, is equity. How do you provide equal education across the globe? How do you guarantee that a student who's in a first world country will have the same experience as a student in a middle or lower class country or level? That's kind of hard to envision, but that's the lofty goal that has been set. And so how do they decide, or how are they thinking about going about that? Is to innovate through teaching and learning practices. And ultimately, they would want to accelerate their meeting of that goal. So there's quite a bit of money that's going into that now. So I'm going to encourage you to follow UNESCO and see the latest and the greatest. But it is out of their agenda for 2030 that they look at having 78% of adoption of AI in global education. So how do we bridge the gap, though? So we're here. We're talking about the goals, having a vision, making it plain, writing it down, and running toward that vision. And in achieving that vision, how do we bridge the gap? Well, that's what I was curious about. So that question led me to further explore what currently exists. So just the aim for the next few minutes that I have is looking at the enhancement of simulation fidelity. So we talk about low fidelity, mid fidelity, high fidelity, and that pertains to like your mannequins and your computer systems. So if you're talking about like medical school, your endovascular simulators for cardiac catheterization, your ultrasound for trauma, looking at the FAST exam, or your nursing, looking at the SimMan, the 3G, or looking at SimMom for delivery, or looking at your preemie for neonatal intensive care. But the goal here is threefold: in enhancing simulation fidelity, in personalizing learning, and addressing ethical challenges. So how can we have students, okay, our max is like 120. How can we have 120 students and we talk about personalizing learning? Who has time for that? Well, the beauty of AI and leveraging AI and using that in simulation will allow us to meet that goal. It's not a matter of if we can, it's a matter of the fact that we must. So here at NCU, boots on the ground, we think that AI can bridge that gap if done in the proper way, connecting your technical skills development with the cultural competencies that are needed. And of course, I know some of you will migrate, but the focus is especially here in the Caribbean because the majority of you will stay. And that's just how the trends have been over the years. So with those three aims in mind, or the aim being those three-pronged, threefold, went about looking at the database and searching the literature to see what existed on that. And so started out with using the PRISMA guideline framework in narrowing literature searches and finding the sweet spot of what you're trying to find. I went from 500 plus articles to 10 that met the goal of what I was trying to, or the aim that I was trying to meet. The studies, the 10 peer-reviewed studies, so they have to be peer-reviewed, can't be just something in the paper or what's on Google or Wikipedia. They were covered from 2020 to 2025. So COVID took our attention, but believe it or not, AI was being looked at very heavily in healthcare. So with the narrowing of the literature through EBSCO, CINAHL, and a few of the other search engines for nursing education through our library, I was able to identify the fact that a lot of people are looking at doing just this very thing that we're talking about. So there are 3 findings that there's a lot, but I just want to narrow it to 3 that I found that was very interesting and that we could actually do right away. It's adaptive simulation environment. So how do we make the environment in such a way that it will be relevant and you will be able to meet the objectives that we have put forth, not just for that program, for that course that you're doing, but for the content of the unit and then, of course, for the overall program. But at the end of the day, also, how do you meet the goals in being competent at the bedside? That you don't harm anyone, knowingly or unknowingly. So that's really, really important. So learner performance, if we adjust platforms, make them adaptive to how you interact with those platforms, user interfaces, it will enable us to make your learning more personalized. So you see, we start with one and we've already met 2 of those aims. So that's how you bring the personalization into the learning experience, because no 2 students learn the same. Even though the content is standardized, your experience will be different because it's based on your interaction with that mode that we are using for that. So we're looking at dynamic AI scenarios with natural language processing. So the challenge that I've found in the last few years that I've been here is finding software that actually would be relatable to the Caribbean. So I have to make a lot of adjustments with some of the things, whether that's in how patients talk, whether that's in how the family dynamics might be, in some of the things that they do while they're in the hospital, in some of their beliefs and how that impacts patient and family education. So here's the big thing for me, because again, I can't help but think about the numbers. When done properly, the integration of this adaptive simulation environment will reduce costs by 67%. Some places have claimed that they could even reduce it even more. But by 2028, that's the projection. So, of course, I talk about theory in practice and applying theory to practice. So this environment that you're looking at is what I sat at my laptop and created just by the input that I entered into AI software. So based on what I wanted as an output, I made sure that I gave it specific commands so that I could create a particular environment that you now see as an output on this screen. And so then the next level, where do you take it? Well, you get the different plug and plays, so to speak, in order to actually have that work on the computer and also have that work when you're doing VR. So when you actually put on goggles, you would be actually a part of this environment. This was maybe about 5 or so minutes that it took me to do that. So that just gives you an idea. This is just a mock-up of an interface just from my laptop with nothing else. And I was getting paid because I was at work. All right. So then, the second finding that I want to bring to your attention that I found as a result of looking at the literature is competency analytics. So you're only as good as the data that you have, but really even further, it's what you do with that data. So everybody collects data, and we have tons and tons of data housed in all sorts of places, and we've done nothing with them. So this is where AI helps us, because as we teach machines to learn, it becomes more intuitive, and there are different levels of machine learning. I do encourage you to explore further, but depending on what it is, as we teach them to learn, they then become more intuitive, for lack of a better word. That's how come you're able to identify certain things in everyday life, like your computer is able to identify whether or not you have a virus on your system because of that machine learning and specific things that are given. So a study in China that I found very close and relatable to here was that through this whole competency analytics, there was a 42% increase of earlier identification of skills gap. So faculty was able to identify earlier where those gaps were for the learners and anticipate and actually be proactive instead of reactive in what they were doing. So for me, that's like a really, really big deal. So if you were paying attention earlier, I had that whole original art with, God and man. Well, came across this. I couldn't help myself but include it here. When we were talking about ethics and the tension that exists between AI and reality, and I don't have to tell you because you guys are social media butterflies, and so you know more about that than I could ever live to know. And so you hear a lot of this stuff about AI and the drawbacks and everything. But I want to remind us here that with great power comes great responsibility. And while we can monetize AI, and it's being monetized, you best believe that, we must guard against the over-reliance on these algorithms. God gave us a brain. We will always be superior to machines. They learn what we tell them. They are not a living being. They are not independent in it of themselves, but we make them so. So keep that in mind. And in a 2024 study, there was a warning about bias to AI performance tools. So you got to know that machines make mistakes. And they make mistakes because we make mistakes. And so sometimes the information that they're given is interpreted totally different than what we thought. I say potato, you say potato. Tomato, tomato. Right? So it depends on the perspective. So, with data privacy, that's another thing. That's a big concern. And when we're talking about healthcare, that's a huge concern. Huge concern for breaches in healthcare, where you can have a hospital being taken ransom, and patients who are dependent upon systems are at risk of dying because of this. So it goes without saying what the ethical challenges can be. But with the ethical tension, just to wrap up this part, while the accessibility increases and the costs decrease, we must also know that we have to safeguard data privacy concerns and sensitivities when we create our scenarios. And some of the research did show that and did guide on how to do that. So that would definitely be something that we would be implementing as we move forward. So what's the significance? So I said like all that stuff. So what? You probably tuned out on some of it already, students. We have to be culturally responsible for training in the Caribbean, in the context of health here. And that was proven in the study in China. We have to make sure that we have protocols in place as far as how we maintain human oversight into machine-guided learning. And then having frameworks frameworks in place that's going to help us to evaluate the impact. Because why bother to do it if you're not going to be able to say that it made a difference to begin with, even if the difference is not what you had anticipated. So for educators, for all of those who promote evidence-based strategies, there's that word again, we need to look at that when we're implementing AI. So to succeed, we need to make sure that we are innovative and that we are also strategic. So, in conclusion, it is predicted that by 2035, strategic AI integration will redefine nursing competency, but only if we collaborate. There are no borders. COVID showed us that. Furthermore, with AI, there are no borders. Viruses don't stop at the border. They don't have visas. But only if we collaborate across border, across nation. Educators, ethicists, and technologists must work together. So let us innovate without losing sight of compassion when we talk about AI and simulation integration. So thank you. And references are available in the booklet. And I know I'd be more than happy to email that if you're interested. Thank you.
Before I proceed, would just like to acknowledge the presence of University President Dr. Lincoln Edwards. Welcome to Nursing Research, sir, 2025. AI-driven simulation in nursing education. 3 focal points were explored. Dr. McLean, I hope I got it right. Future trajectory of nursing education, AI, and simulation. 2, ethical considerations in AI implementation and simulation-based learning environments. Are there any questions for Dr. McLean? Any questions?
So good morning, everybody. All right, so my question is, as, for example, a nursing student who's interested in AI, how can I get into a career that involves both nursing and AI, for example? So how would I, being a student, probably being soon to graduate, enter into a profession where I can integrate both my nursing knowledge and AI? Yeah, that's my question.
Just stay in nursing. AI is in nursing. So it depends on what your interest is and what you mean by AI. So this is where I want to encourage folks to look at what AI is and how it's defined. It is so far-reaching. So what in AI are you wanting to go into? Is it robotics? Because that's in healthcare, because they do robotic surgery. Is it in diagnostics? Because that's in healthcare. So healthcare has merged the utilization of AI, the existence of AI, and it's always really been in healthcare with that. So with nursing informatics, that would be a really good area to look at in taking that as well. And there are other things that are available now online that you can either do your own driven learning, or you can actually, we have a great computer science program, have a great lab with a lot of AI stuff here at NCU, so you can, when you graduate, you can come back again and do a second degree as well.
Okay, is there any other question? Okay. Doctor.
Thank you. I'm just monitoring the chat on YouTube, and I see where Dr. Alonge asked, is it ethical? And I think it's in relation to your mention of emotion recognition and communication. So she's asking, is it all ethical? When you mention the emotions, right, and the communication, She wants to know if it's all ethical.
If using AI to simulate that?
And with the emotional.
Yeah, absolutely. It's so critical because when you think about your neurological, diseases, when you think about stroke, sometimes with those patients who can't demonstrate facially, and students, you know this, when you're interacting with them, having that appreciation and understanding that and seeing that, because a lot of times you're going to go through clinical rotation and not see some of the conditions that we talk about. And this is where we can maximize the utilization in the lab to simulate some of the stuff that you probably are never going to see. So with the ethics, it is the utilization and it is the motive. Why are we doing it? Is it to improve care at the bedside? Is it to have best practices at the bedside? And that is the foundation upon which ethics has to be built. And we have to stay in control of that as humans and not allow AI to be utilized for anything that would be nefarious or otherwise. So Dr. Alonge, I hope that addresses your question. I think I understood the question.
Any other? Okay. Our next presentation will take the form of a panel discussion titled Artificial Intelligence in Nursing. Is this the future? It will facilitate a crucial dialogue between faculty and students and will seek to bridge theoretical knowledge with practical implications. Our moderator for this section will be Rajan Miller. I hope I got the pronunciation correct. Rajan Miller is a devoted Seventh-day Adventist who cherishes her relationship with God and strives to honor Him in every aspect of her life. Having journeyed through all of NCU's educational levels, from daycare to university, she has built a robust foundation in Seventh-day Adventist Christian education. Her life has been a composite continuous service and leadership, woven with threads of dedication and purpose. As the VP of Spiritual Affairs in the NCU Science Students Association during the years 2022 to 2023, and later as the VP of Spiritual Affairs in the USM 2023 to 2024, she has demonstrated her commitment to uplifting her peers. Often seen with a radiant smile, Rajan delights in spreading joy and laughter to those around her. Her passion for media and communication inspired her to launch the Hope podcast on YouTube, where she shares the message of God's love like a beacon of light in the digital world. Feeling a divine calling toward nursing, Rajan currently serves as the freshman class president of the nursing program, leading her peers with grace and enthusiasm. Her journey is a testament to her unwavering faith and commitment to making a difference in the lives of others. Rajan will introduce her panel. Kindly make the panel feel welcome.
Good morning, ladies and gentlemen, nurses and faculty, all persons here, including the media team. As stated earlier, I am Rajane Miller, and I am excited to be here on this panel discussion. Now, I have 4 panelists here with me, but we actually have 2 persons online. Can that be confirmed? Do we have the 2 panelists online? Okay, waiting for, yes, they're here. All right, so I'm gonna just be reading the brief profiles and then we'll get right into our discussion. So, Miss Chantal Johnson, and they're gonna wave as I call their names. Miss Chantal Johnson is a 22-year-old senior nursing student at Northern Caribbean University, where she maintains a GPA above 3.0. She's an alumna of Marymount High School in St. Mary, where she had the honor of serving as head girl. Her commitment to healthcare and community service is demonstrated through her active participation in health fairs, conducting blood pressure checks, donating packages to families in need, and taking part in school medicals alongside healthcare professionals. Throughout her journey, she embraced leadership roles in her community and has been elected as youth counselor for the parish of St. Mary, the council that is, and served as president for her local youth group. Her passion for nursing is driven by a genuine desire to serve others, and she is driven by her faith in Christ, guided by the biblical principle that the care you give is the care you hope to receive. Please give a round of applause for Ms. Chantal Johnson. All right, our next panelist is Mr. Floyd Hill. He is a third-year nursing student at NCU, and he has a strong passion for healthcare, technology, and innovation. His academic journey is marked by excellence, including a grade 1 in Introduction to Technology at the secondary level and outstanding freshman for academics. Beyond nursing, he has a deep interest in technology, particularly PCs and digital advancements, exploring ways to integrate innovation into healthcare. One more round of applause for Mr. Floyd Hill. All right, now we have Miss Brenda K. Bartley. Get that right? All right. She's a final year nursing student at NCU, of course, where she demonstrated an outstanding academic performance and unwavering dedication to health care. She has accumulated over 2,000 hours of clinical experience in diverse areas, including medical surgical nursing, psychiatric nursing, gerontological nursing, and primary health care. She has served in many leadership roles, and with steadfast commitment to healthcare and education, she stands as an inspiring role model for aspiring professionals, such as us freshmen, right? Please make her welcome, Miss Brenda K. Bartley. All right. Now we have Miss Sedane Spence, a junior nursing student, driven by a passion for nursing leadership. She's one of our panelists online, actually, and she's recognized for her excellence as she earned the top freshman female in nursing 2022 to 2023 and the Stellar Citizen Award 2023-2024 for outstanding academics and service. Beyond nursing, she advocates for environmental conservation and social justice, striving to create a more sustainable and just society for future generations. One more round of applause for Miss Sedane Spence. And last but not least, Miss Ashley Scott, senior nursing student and the class president for the class of 2025. She has always demonstrated strong leadership and has held various key positions throughout her academic journey. With a keen interest in AI in nursing, she's eager to explore how AI can support clinical decision making. Guided by the philosophy that nursing is both an art and a science where innovation must complement empathy, she strives to embrace technological advancements while ensuring that patient-centered care remains the focus. Miss Ashley Scott. All right, and last but not least, we have our member of faculty, our beloved supporter, she said, Dr. McLean, who just did an exceptional presentation on AI. Now let's get right into our panel discussion. The first question is, how is AI defined in the healthcare industry? Any person can answer. It's an open question. Feel free to share.
Okay, good morning, everyone. Yes, let me first start off by saying it really is an amazing opportunity for us to gather in this fashion to talk about healthcare and its impact on our patients. Let me first say as well, AI is not just ChatGPT. That I realize that's a buzzword that keeps going around. It is so much more than that. It encompasses a wide range of applications that enables machines and also computers to simulate human cognition. What it does, it actually comprehends, it can solve problems and make decisions. And in some cases, AI can either augment or exceed human capabilities. Now, in an article entitled Artificial Intelligence in Healthcare, Transforming the Practice of Medicine, Bahwa and his co-authors defined AI within the scope of healthcare as advanced AI algorithms that actually improves patient experience, it enhances diagnostic accuracy, and supports clinical decision-making by processing a vast amount of medical data and also recognizes patterns. Now, I'd like to say, this is not a new concept in healthcare, as Dr. McLean spoke about earlier. And according to Raman and company in a 2024 study, AI has been used from the 1950s till around the early 1970s. And there was a research from Stanford University where they created the mycin system. And when we hear mycin, we think about the medications, right? The antibiotics like azithromycin. What this was, it was an early experiment system that actually identified bacterial pathogens and how to treat them with antibiotics. Thank you.
All right, thank you so much, Sidine. Does anyone else want to add? Or is that okay? It's okay, okay. Our second question is, what are the benefits of integrating AI in nursing care delivery in Jamaica?
Thank you so much, Rajani. That's it. All right. So good morning again, everyone. I'm sure a lot of us can testify that AI is very quick, because I'm sure when the question was asked earlier, a lot of us took out our phones and typed, and we got a quick response. So yes, that's one of the benefits, but specifically in healthcare, it helps to enhance the care that we give. So AI is able to analyze the patient's vital signs when it is entered in, and it also helps to store it. Another benefit is increased efficiency, as stated before. So it's very quick, and it is seen where the National Institute of Health in 2024 says that a 20% reduction in hospital readmissions has been seen when AI is being implemented. Isn't that awesome? You know, the patients are not coming in often because of the fact that they have access to the implementation of health online. So they can stay from home and type in, I have this symptom, and should I go and see a doctor? And so because of AI, they're able to do that. Additionally, it enhances access to care. So you have chatbots that can provide preliminary assessments, as I mentioned before. So you can go online and speak with medical officers through AI, and instead of going in person. And I know it can be very costly to be traveling all the way to other parts of the country. For instance, if you live in St. Mary like me, way up in the bushes, there are health electronics that you can go online and you can speak to a medical officer and they assist you. So yeah, that's really it. So it is quick, it helps with easy access for the nurses, and you know, one of the things that I love is that AI allows us as nurses to also have direct patient contact. So instead of standing and writing our notes for all the shifts, I know most persons do that, you get to know not just the patient's condition, but who they are, and you build that therapeutic relationship. Yeah.
Thank you so much. Our next question is, what is the biggest hindrance to incorporating AI in nursing?
Okay, good morning, everyone. So I would say one of the biggest hindrances is, as Dr. McLean presented, ethical concerns. I know concerns about privacy as well, because not only can the systems be hacked or, ransomed, but some healthcare workers themselves aren't very ethical or professional. So sometimes there is the potential for the data to be misused. But also, I would say another big hindrance is resistance itself. So us as healthcare workers might think that AI would replace some of the roles that we would play with the patient. So would the AI know more than me, the nurse? I mean, chances are, because the AI is able to gather information from so many sources, the AI may know more than you in some sense, but you as a nurse is the one that's actually there with the patient, there in the setting each day. So you would use your knowledge and transfer the AI into real life application. And another hindrance that I see is the potential decline in critical thinking skills. Because even as a student, sometimes I have to catch myself, because I'm like, Brenda K, why are you putting that in Chat GPT? That is what you're supposed to can sit down and do. But sometimes, the brain's so tired. I'm just, all right, Chat GPT, just deal with this. But I think that's a potential hindrance as well. So the lecturers might think, all right, because of the AI, the students are not going to do the work, which, is that true?
Dr. Malkin, you wanted to add?
I think something to add, and in thinking about the culture, cost is a huge thing when you're thinking about AI, and even in nursing, but just across the board. But since we're specifically talking about nursing, it is astronomical depending on what it is that you're implementing. So sometimes people would say, competency, lack of standardization, but if you really drill down, it comes down to cost, because one hospital can be a major hospital that has a lot of revenue and they have contingencies for AI and they can put that toward that. Where another hospital, they're seeing 10 patients or so in little Podunk County in the country. What they gonna need AI for? They'll send them to the bigger hospitals that have AI. So that's a huge thing that should be considered. But what I think, you never find an issue without thinking about a solution, is where governments and politicians and the keepers of the purses need to set budgets, future budgets that have, a line item for AI. Because whether or not we're ready, it's here, it's been here, and we don't want to be left in the dust. So it would definitely be something that the government needs to look at a framework from a national perspective and set that up, and then start saving for what that looks like, so that we can definitely improve healthcare.
So a follow-up question to this is, let's say AI is successfully implemented in nursing. What are some likely pitfalls you think could be present due to this implementation?
All right, so in regards to your question, as Dr. Mackley would have mentioned, doing that we don't really, I don't want to say Jamaica is a poor country, that would be wrong, but we're middle class, and so cost can be one of the pitfalls. We don't have enough money to get the resources in order to implement these systems. And also digital divide. So you do know that there are still places in Jamaica that does not have access to internet, and these are like health centers. So if we should implement AI, it would be a big effect on them, seeing that they're in places where they don't have any internet access, so they're not going to be able to use these resources. And then, as my colleague would have mentioned, resistance to change. So there are still nurses. We have the seasoned nurses that are used to taking up their clipboards, writing their notes. And one of the things about change is that there will be resistance, because you're so used to this thing, and now all of a sudden you're going to have to let it go. And then you're saying, oh, is this going to replace my job, as my colleague would have mentioned? And also ethical and privacy concerns. So I recently heard on the news, Jamaica Information Service, I think it was last week, Thursday, March 4th, where it was seen that cybersecurity in Jamaica is not as strong, and they're trying to push it. About 4 million attempts of cyber attacks within last year coming up to this year. So can you just imagine, they are not going to implement it, and then when you look, I can see the world knows that my relative have this, so everybody's information is on the media. And I'm sure we also experienced it where a couple, like it was last week, where they hacked our school's ARI. And so it just shows that the cybersecurity is not strong enough, so it prevents them from being able to implement the AI system.
All right. Allow me to shift the focus. Dr. McLean, did you want to say something?
No, I was totally echoing. And when she said 4 million, I'm like, wait a minute, there's about 3 million-ish. So that's at least like one per Jamaican attempt if we're all attempting to preach. So yeah, so definitely the privacy and the security.
Allow me to shift our focus a little bit from nursing in the hospital or in the healthcare setting to nursing in the classroom. So nursing students, that is. So what are some ways, panelists, that AI can be utilized to improve student performance in the classroom? And what are some ways it can be used to hinder student performance in the classroom? So both improve and hinder in the classroom.
Okay, thank you for that question. I'd like to say that since using AI, it has tremendously helped with my schooling. And I believe that one of the greatest advantages of AI is actually how it's able to personalize learning to that individual. And as nursing students and wider, all of us, we all have our strengths, we have our weaknesses and various learning styles. What AI can do, it actually analyzes our performance patterns and also can recommend various materials or study tips on how we can make improvements. Now, AI has helped me to identify what my learning style is, and I'm an auditory kinesthetic learner, which means that I learn best through listening and also engaging in hands-on activity. Additionally, AI can simulate patient interactions that can mimic real-life clinical scenarios. And Catherine Seibert and her colleagues in a 2019 literature review actually highlighted that simulations improve critical thinking and decision-making. Now, whether it is that you want to manage a patient with hypertensive crisis or asthma, we actually can input these data within these AI-generated systems so we can build our competence and our confidence in a controlled setting. And for my third year nursing students, hint, hint, if you feel like you are not so versed with doing the MSE, you actually can plug these in and do some real practice questions. And lastly, AI actually provides automatic feedback questions where it actually can reduce the wait time and explain exactly what we need. Now, one of my struggles is that sometimes when I get questions wrong on tests or even doing assignments and I don't get the maximum points, I don't want to know why is it that I'm making these mistakes. And if we don't have an explanation to this, of course, we'll make them same mistakes over and over. So what AI can do, it actually can give you instant and also evidence-based feedback for quizzes and also written responses. Also, did you know that AI can help with your nursing notes? I found this out. This was in my second year when I was doing my rotation. I'm new to the hospital, new to writing. And if I had a scenario where my patient's right lower hand is swollen or red, did you know that this is what AI generated for me? The patient presents with erythema and edema of the right distal upper extremity. That shows you that this actually can help you to tailor it to whatever you need. Now, as you were talking about the hindrance, this was mentioned earlier. A lot of persons, they actually rely heavily on artificial intelligence for their schooling, and as such, studying is reduced. A lot of people, when they're doing their assignments, they would just plug the prompt in, copy it off, and at the end of the day, what is it that they have learned? So I believe that we need to make the distinction that AI is here to enhance learning, but we should not heavily depend on it, because at the end of the day, we are nursing students. We will go out into the clinical field with real-life patients, and we should be able to have the information so we can give them the best care possible.
Thank you. That was a powerful answer. And you know, actually, I also, even though I'm not answering one of the questions, but I actually did a little research, and I found, I think we all know this as nursing students, the brain is like a muscle. It stays fit with sustained focus and deep thought. Constantly exercising your mental abilities is what builds your mental capacity. Now, with using AI, it should not be that AI becomes your brain. It should be that if you must use it, it is assisting you in using your brain. It should not be that if this is the AI, you take it up and give it to the teacher and you have no idea what you just handed in to the teacher. And I've seen it many times throughout my various classroom experiences from high school, university, nursing school. Many times it's so easy, especially when you have an influx of assignments, when the teachers wake up one morning, sorry to all the teachers here, but just get up and say, hey students, I have an assignment for you and it's due today. And you're like, huh? Excuse me? And then you have to process everything. You have to get the correct answer, and you have to bear in mind that not only is this going to affect my future patients, but it's also going to affect my grade. So balancing all of that, it can be so easy to just find, like Sedaine said, it's not just ChatGPT, but find whatever AI source you can use and just put the question in and just take the answer and just give it to the teacher and have no idea what you sent in. So it's important to balance. But yes, back to our panelists. The next question is, as future registered nurses, how do you envision the impact AI will have on nursing responsibilities?
Okay, that's a good question. I think that AI, artificial intelligence, can really help us as future registered nurses to make our workload a little bit lighter, because not saying AI is going to come in and take care of the patients, because, nursing responsibilities is more than just taking care of the patients. As nurses, we have a lot of administrative tasks. So, we have to write assignments, we have to write the diet sheet, we have to document. It's a lot. So, as Dr. McLean said, we're already implementing EHR, which is electronic health records, in the different hospitals across the island. So if there is some amount of funding that can be put into streamlining an AI into the system, then even scheduling nurses for shifts or updating diet sheets or assigning patients to beds, because I know that's sometimes a problem, trying to figure out which bed to put a patient. And AI can do all of that. Not saying that AI is going to do the work and you just say, okay, the AI said this, so let's work with that. But it's artificial. So as we said before, you as a nurse would come alongside and try to put what the AI has given you into the context that you're in. So also, as Ms. Johnson mentioned before, chatbots are a thing. So sometimes the patients don't need to come to the hospital. It sounds weird, but sometimes the patients really don't need to come to the hospital. Like, it could be something minor. The hospital could have a chatbot on their system where the patient can put in their symptoms and whatever. And if it's something that needs to be escalated, then a nurse or someone else could step in on the system and escalate that. And then if the patient needs to come in, the patient would come in. Because a lot of the times the patients would end up calling the hospitals, and sometimes there's nobody to answer the phone. So there's no one to escalate that. And I think that could also help with triaging the patients as well. So based on the patient's complaints, you know that, okay, this is emergent or urgent or non-urgent. Also, I think that AI can also help to reduce certain errors that could be made, because if there's an AI in the system, then it would flag certain interventions. Say, for example, a patient was prescribed an antibiotic for 7 days, and the last dose has been given, and the nurse would go to give the dose, like maybe it wasn't written properly. The AI could flag it and say, okay, the duration of this medication has been exceeded. So I feel like a lot of errors, and the workload could also be decreased as well, seeing that there's nursing shortage. So the nurse could spend more time with the patient, as Ms. Johnson said. So the nurse would have more time at the bedside with the patient instead of doing all of these administrative tasks.
Thank you so much. I just got the time limit, so we have 2 minutes left. So we have maybe time for 1 or 2 other questions. All right, so what are some of the biggest risks of AI in nursing care?
Okay, so in recent research, there have been several risks associated with incorporating artificial intelligence in healthcare were identified. So the first risk is socio-ethical risk. Because AI systems usually rely on large data sets that may reflect societal biases, historically marginalized groups such as ethnic and racial minorities may be underrepresented or misrepresented in these data sets. And this now results in the patient not getting the optimal care that they need. So an unbalanced data set may lead to inaccurate predictions for these groups, and then this may worsen the patient's health conditions. You also have gender biases, and you also have a situation where the vulnerable population, which lack access to healthcare services, as aforementioned, they may not have access to AI, and then this creates a digital divide. And this, it kind of reduce the amount of care that the patient may get. The second one is privacy and data protection. Chantal mentioned it before that the cyber attacks, they're getting more frequent. So using AI in healthcare also raises concerns about the data privacy, confidentiality, and the protection of patients' rights. So these risks include the exposure and potential misuse of sensitive data, and this could lead to violations of the individual rights as well as non-medical uses of personal information. And lastly, you also have the risk for AI making unfair or wrong decisions. So AI can also make mistakes, just in case we never know. Because sometimes when you're using ChatGPT, it may say the information given it may not be correct, and you may check with other sources. So if an AI system is trained on data that doesn't represent all patient groups equally, it may provide incorrect diagnosis or recommendations for some people. And this can lead to poor treatment and medical errors, which could have serious consequences.
Thank you so much. So with the benefits and the risks that we just heard answered in mind, what are some of the emerging trends in AI technology that will impact how nursing care is administered in the future? And this is our final question.
All right, so good afternoon, everyone. So first we have predictive analytics. This is where the AI can help to anticipate health deterioration early. This can lead to early interventions, right? We also have enhanced diagnostics. As my colleague said earlier, AI is efficient and it can help to increase our efficiency, which can later on reduce mortalities. So we also have virtual assistants and chatbots. My colleagues mentioned that before, right? It can improve patient post-discharge and care engagement, right? We also have administrative optimization. I think my colleagues mentioned before that Jamaica is a middle-class country, and so optimizing our administrative tasks may be a bit difficult, so the AI can help with that, can also help to allocate resources better so that we can deal with our resources better so it doesn't run out quickly because we don't have a vast amount of resource. And it's also being used in nursing education, as Dr. McLean talked about earlier. AI-based simulations are enhancing nursing training, giving students a more realistic feel of what to expect when they go out in the clinical rotations. And so you know what to expect as nursing students and future professionals. And so we also have challenges. As my colleagues mentioned, this is a general overview. There are ethical concerns with AI, such as the resistance, breach of patient information. So that sums up the emerging trends for AI.
All right, thank you so much to our panelists for making yourself available and for giving such answers. And I just wanted to say something from Dr. McLean's presentation, just to wrap it up. we should always be superior to machines. And I want to add, God gave us dominion over everything, but He has provided so many resources for us to maintain that dominion. And AI is one of the resources that have been built up due to what God has allowed us with our brain capacity to build AI. So we should use it in the right way. Thank you so much.
AI versus HI, artificial intelligence versus human intelligence. AI has immense benefits and immense potential into which we have yet to tap. However, nurses, please remember that AI cannot replace the caring aspects inherent in nursing. Would like to thank Dr. McLean and Rajan and her team for section 2, which looked at AI and simulation in nursing education. Nurses and other healthcare givers are known to have gifted hands. To display her gifted hands in another format is Oloy Green, a senior nursing student. Ms. Green.
Isn't it?
what are you?
Gifted hands and dulcet tones. We will go straight into our third and final section. This section looks at health and wellness integration, contemporary health challenges. These three presentations are significant in that they look at modern healthcare concerns. 1, digital dementia, your attention please. 2, diet, lifestyle, and cancer health disparities. Is there a connection? And 3, recipe for achieving mental wellness in unprecedented times, implications for patient care delivery. Jean-L. Miller, a committed advocate for nursing, education, and holistic health. Jean-L. Miller is a compassionate registered nurse with 25 years of experience, currently making her an assistant professor in the Department of Nursing at Northern Caribbean University. A proud graduate of Seventh-day Adventist tertiary education, she earned her Bachelor of Science degree in nursing from what was then known as West Indies College, now Northern Caribbean University. Her academic journey continued at Loma Linda University, where she obtained a Master of Science degree in nursing, specializing in nursing education and adult and aging family. Janelle is also diligently pursuing her PhD in nursing at the same institution. As a devoted nurse educator, Janelle is deeply invested in crafting effective curricula, instilling a sense of compassion in her students, and cultivating critical thinking skills through a variety of engaging teaching methods. Our commitment to holistic health and living propels her initiatives aimed at enhancing nurses' well-being and encouraging active collaborative learning. Janelle passionately shares her belief in God's plan to make man whole, presenting her insights in diverse settings, both locally and internationally, inspiring others to attain their highest levels of wellness. The greatest joy for Janelle comes from witnessing her students unlock their full potential and motivating her colleagues to adopt active learning strategies that truly address the needs of their clients. On the home front, Janelle enjoys a fulfilling life with husband Roger and their two children, Rojan and Roger. Together, the Miller family facilitates the Destiny of Hope seminar, a heartfelt initiative dedicated to helping participants find meaning, healing, and a profound sense of their inherent worth. In her leisure time, Janelle delights in gardening, cooking, connecting with new people, and expressing her thoughts through poetry. She treasures family moments and dedicates time to exploring God's Word, drawing strength and inspiration to guide her through the day. Ladies and gentlemen, kindly welcome to the podium, Mrs. Janelle Miller.
Thank you for those very kind words. I had to be wondering, Ms. Braham, what did you do? Good morning, everyone. Good afternoon, everyone. Well, at least I got your attention just a bit. But I'd like to ask you a question. If today all your Google contacts for some reason went down, your phone contacts disappeared, how many persons would you be able to call? Just think about it, and come up with the number. All your contacts disappeared from your phone, and your Google contacts disappeared. How many persons would you be able to call? Oh, you're stranded, by the way, and need to call someone. How many? Wow. Isn't that something to consider? 2. Anybody more than 2? Anyone more than 5? And how many contacts do you have in your device? Hundreds. That's something for us to consider. I need your attention because there is a phenomena that has taken the world by storm, that has been coined to be called digital dementia. Digital dementia. So my next question to you is, how many of you want to be exceptional, empathetic, caring nurses who can sense your client's needs, can assess the needs appropriately, and be sensitive to the client's facial expression, body language, and also be able to relate very well on an interpersonal level? How many persons? Let me see your hands. Oh, some are not really interested in that. Okay. How many persons want exceptional cognitive ability? Wants to be brilliant and be able to identify your client's needs based on your assessments? I see a few hands. How many of you want to be able to control your emotions? Well, I'm happy that at least some of you want that. I'm asking these questions because they are rooted in a very crucial part of the brain, and you know I love to talk about that part of the brain. It's amazing. But as we're thinking about digital dementia, CDC, yes, I don't mind. CDC dropped a bombshell. CDC said that by 2060, they are predicting that there will be a twofold increase in dementia among 65-year-olds and above. And by 2060, guess who would be the ones in that age range? Yes. Now, when we think about dementia, though, when we think about those estimates, there are two things you want to consider. That estimate of a twofold increase in dementia was using the same characteristics of persons born between 1925 and 1965. So they used the characteristics of the silent generation and the baby boomers to predict that by 2060 there will be just a twofold increase in dementia. What is different about the baby boomers and the silent generation versus millennials and Gen Z? Two crucial factors we want to look at, and Manuel et al. 2022 highlighted those two factors that we need to consider, especially as we think about dementia risk. The first is overall intelligence. So according to the reverse Flynn effect, globally, intelligence has been reducing since 1975 by IQ points of 1.28. And it's expected to get worse by 2050. It's like going down a waterfall in a canoe. So the decline in IQ has been heightened since the year 2000 by environmental factors. I wonder what happened since 2000. Another factor to consider that makes it different, that's different about Gen Zs and millennials versus the baby boomers and silent generation is excessive screen time. And by the way, excessive screen time, as the literature puts it, is between 2 to 3 hours per day. That's excess screen time. Now, it's excessive, especially during brain development. And we know the frontal lobe does not fully develop until about 25 to 30. So we're talking about active brain development happening for our Gen Zs and millennials. Are we seeing that? Now, whenever there is excessive screen time, during this time especially, learning is impacted, memory, attention, and emotional impairments can occur. Higher risk for substance abuse, changes in the gray and white matter sizes. So our gray matter processes the information and the white matter will help with our transmission to different parts of the brain. So really and truly, according to Manuel et al. 2022, they actually suggest that because of the Flynn effect, the reverse Flynn effect, where the intelligence is going down, which is one factor for dementia, and number two, excessive screen time, the previous generation that we're talking about did not have screen time in terms of mobile devices. They would have to probably go to the theater to see people do their thing on stage, right? So they did not have the screen time. So the record, based on other systematic reviews, it's really a 4 to 6-fold increase in Alzheimer's disease and related dementias after 2060. Can you imagine the disaster in the healthcare system? Now, let's talk some more about this. Now, when we talk about screen time now, we're not just talking about our smartphones. We're talking about TV, computers, mobile devices, tablets, and laptops. So the aim of this literature review, which was done on health promoting presentation, the aims are to sensitize participants to the correlations between excessive screen time and undesirable health and well-being outcomes, and to emphasize lifestyle choices that could preserve cognitive function. Also to encourage a conversation regarding digital balance in this overwhelmingly digitized age, because it's here to stay, right? We just talked about the importance of AI and other digital devices. So we want to encourage this conversation. So Manfred Spitzer coined the term digital dementia, and this is cognitive decline associated with excessive reliance on digital devices, that is smartphones, laptops, TVs, potentially exacerbating Alzheimer's disease, potentially exacerbating attention deficit hyperactivity disorder, and memory loss. Please don't look so forlorn. So when we think about dementia, we're looking at a group of symptoms that really result from brain damage, and it will impair our cognitive function, and that's beyond what's happening naturally during the aging process. It affects our emotional regulation. Remember, we talked about being able to handle your emotions. It affects behavior, and it affects your motivation. All the while, consciousness is still maintained. So the question is, like, who am I when I become demented? As we focus on the chronic sensory overstimulation that comes with excessive screen time, we see that it affects brain development and increases the risk of cognitive, emotional, and behavioral disorders in adolescents and young adults. Interestingly, emerging evidence suggests that some of these effects are similar to those that are seen in older adults during mild cognitive impairment, the stage before we get into the Alzheimer's or dementia. So this is what is being seen now in adolescents and young adults, not just in older adults. So we have memory problems, we have difficulty with social functioning, even self-care. Excessive screen time has also been known to alter the gray matter and the white matter volumes and increase the risk of mental disorders, impairs how we can acquire memories and learning. This overstimulation during brain development increases risk for accelerated neural degeneration in adulthood. So, digital dementia, when I searched the literature for systematic reviews using EBSCO and Google Scholar and PubMed, I came upon Manfred Spitzer. He's the one who coined digital dementia. And so digital dementia is cognitive decline associated with excessive reliance on digital devices, potentially exacerbating our memory loss. Have you thought about that? We know exactly where to find the information, but not necessarily what the information is. We know where to find the fact, and so we are better at intuitive thinking, but we may not know the fact. So we have, based on the literature, reduced analytical thinking. That's something for us to think about. As was mentioned in the panel discussion, the brain is a muscle that needs to be used. Can you imagine 86 billion neurons in the brain, in that 3 pound of flesh in our head? 86 billion, and then we have over 100 trillion connections being made with other neurons in the brain. What an amazing, I don't want to digress too much, I'll get too excited about that. But what an amazing thing God has done to create this brain. And so we need to take care of it. And this is where God talks to us. So what are some of the effects of digital dementia? One of the main problems with digital dementia I would mention is offloading, excessive offloading. So, if I need someone's number, what would I do? Find the name, right? Instead of learning the number. We used to know numbers. Never. Well, some of us used to know numbers. We used to know numbers, but now we offload. We used to understand how to do our drug calculation, older nurses, without the calculators, but now we just use a calculator. I love NCU. It's for a reason. It will build your brain capacity. All right? And so offloading is a big problem, where we revert to devices rather than using our brain with so much capacity. And if we don't use it, we will, especially in your stage of development. And I'm not picking on you, it's all of us. There is also neuroplasticity where the older ones of us, our brain cells are still growing and so on. But the less we use it, the more difficult it is for us. So as we look at some of the effects of digital dementia, so we mentioned already gray and white matter changes. The limbic system that controls our emotional reactions, those get smaller. The frontal lobe may get smaller. So it thins, and so there's less metacognition. Our attention and concentration is also affected. So it's difficult for us to concentrate. It's difficult for us to sit still. It's difficult. We're so easily distracted. We have to keep being stimulated. And then we have learning and memory challenges. So there could be impairments in sensorimotor skills. There may be impairments in problem solving, impairments in our vocabulary, being able to read and understand, impairment in, so we use superficial effort when we want to retain information. So we are excited to get that PowerPoint from teacher, right? Rather than struggle to make one. It's the struggle that causes the learning. It's the struggle that causes the learning. Poorer long-term memory, poorer academic performance, and a part of that is the multitasking that happens while we're on the screen. So we can be handling 5 things at the same time. Like a social media account, we're attending to an email, and we're also searching for some information that the teacher just asked. But I'm responding to mommy, and then that loving one is sending a message to me, and I'm responding to him too. All of that all at once. This multitasking reduces our ability for attending. Additionally, impaired emotional regulation is another challenge. Impaired emotional regulation. So we may have self-esteem issues, self-care issues, more anxiety, more social anxiety. So we want to have friends and we want to connect, but we would be sitting, as someone mentioned, she observed 2 young people on a bus, and somehow she said she did see that both of them were on a dating app. And based on what she could see, both of them were exploring someone who met the characteristics that appeared of the person sitting right beside them. And they never said a word to each other and went their separate ways. Reduced social interaction because we are so glued to our screens. It can influence lower productivity and curiosity, fewer social interactions, uncooperative attitudes and behavior, and sexual activity. Of course, if the frontal lobe is being suppressed, that kind of restraint would be a challenge. Another issue is mental disorders and substance use. So there tends to be an increased risk for addiction and social anxiety, depression, aggression, rule breaking, and hyperactivity. And then impaired physical health is another challenge, because with the screens would come decreased activity, physical inactivity, It also impacts our sleep quality and quantity, especially if we use the screens just before bedtime, 1 hour, within an hour of bedtime. So because of the blue light that is emitted, it tells the body, it's morning, let's keep awake here. There's no time to sleep. We have things to do. And so it's difficult for us to calm down and get the rest that we need because of the blue light. Then the reduced physical activities, of course, will lead to sedentary lifestyles, which of course will lead to cardiovascular issues, obesity, difficulty handling stress, and of course, increased risk for physical disease. So the next question is, as was mentioned before, these things happen mostly in older adults who are heading toward cognitive decline, toward Alzheimer's disease, dementia and Alzheimer's disease. So let's get to what are some possible solutions. Because in truth, can we avoid dealing with technology? Not now. But what are some things that we can do to boost our cognitive function? So number one, when possible, less screen time. Try to contain your screen time. At least with social media, when you're tempted to do the scrolling, the dead scrolling, the zombie scrolling. And so I want to know what's next. And then there is a dopamine rush that happens when I see the next thing. And I'm wondering, I don't want to miss out on what's the next thing. So I have to keep scrolling and scrolling. Limit the time you spend on the social media. Set a certain time per day. I know this sounds crazy, but it's all up to our choice. All right, it's your choice. When possible, write with your hands. So some studies have shown that the actual writing on paper, the struggle and the fine motor coordination that's needed to write on paper, it's like you're writing on your brain. It makes it more encoded in the brain. So a study was done in China where a comparison was made between writing, drawing, and working on a screen. Writing on a screen, or typing, sorry. Writing with a stylus, and then writing with a pencil, drawing, and typing. And what they found was that the connections that were made in the brain, and this was with an EEG being done. So the connections that were being made between the neurons in the brain were more significant as there was drawing and writing, even with using a stylus. But of course, writing on paper with more struggle and the friction from the paper, that can increase the impact it makes on the mind. So don't throw away your books. Write. Take your notes with your pen and paper if possible. Okay? Okay? All right. Another thing we can do is, I did say it. Read more hard copies of books. Yes, if you can. Anytime you can, try to get more hard copies of books. The act of moving the pages along and moving the pages along, the act of moving the pages along and that hand involvement actually helps also with retention. Seeing the text on the page is absorbed, based on what the studies have shown, is absorbed more readily than seeing the text on a screen. That's really something. So if you can read your Bible, if you can, let me put the comma at the right place. If you can read your Bible in the text, in the paper, over your device, if that's possible, okay? All right. And there's one thing I'd love you to do. I'd love you to take God at his word. Psalm 119, verse 130. It would be nice for you to write that down. Psalm 119, verse 130 says, "The entrance of your word gives light and gives understanding to the simple." You ever feel simple? You ever feel like you're not learning? Try God's word. The entrance of thy word giveth light and understanding to the simple. So definitely read the word of God. Here's another text. Psalm 119, verses 99 and 100. And I just love that, especially for you nursing students. It says, "I have more understanding than all my teachers." Hello? Nobody's intrigued. "I have more understanding than all my teachers." Some of you have not yet met all your teachers. "Because for thy testimonies are my meditation." So as I spend time in the word and think about it, my understanding goes higher than all my teachers. And then I understand more than the ancients, even the ancient nurse theorists. More understanding because we keep his precepts. So spend time in his word. Did I mention writing with the hand already? Yes, we talked about writing with the hand. But study the Bible, especially the books of Daniel and Revelation. Because of the high abstract content, that will help to keep our brain function, and that will help to reinforce cognitive skills. Spend more time outside, in green spaces, and definitely gardening is a bonus. Being outside will increase our intake of negatively ionized air, which is very helpful for learning in all mammals, all of us. It will help with our mood as well, more serotonin. And another thing, gardening, as you move the dirt, that will cause Mycobacterium vaccae. You'll be able to inhale that germ, which is harmless to humans, and it will interact with your neurons to produce the happy hormone serotonin. So being in the dirt, I hope some of you still have something growing, but being in the dirt, being in the dirt can help with our cognitive function and our happiness. Encourage, of course, we talked about physical activity, especially outside, not inside. And as we do the physical activity, especially activities where you are having to focus, like your badminton or even pickleball, those things will help you help the cognitive function. So I'm hoping that somehow your awareness regarding cognitive decline that's possible because of excessive screen time has been increased. And I'm hoping that nurses, nurse educators, and you students and other attendees will choose to adopt and share some lifestyle habits that could preserve your cognitive function. I did not go into diet or even, many other things, but I'd encourage you, for those things that were shared, that you integrate them in your lifestyle. I'd also encourage you to visit the site, Health Professionals for Healthy Screens. Health Professionals for Healthy Screens. They give guidelines regarding how much screen time is recommended for babies. So 0 to 2 years should not be exposed to screen. Can you imagine what happened to the millennials and the Gen Zs in daycare? It's only screens, or we use a screen to put the baby to bed, or keep him quiet, here's the phone. Let them go outside, I agree, and play with the ants. Observe the ants. The best mobile would be the trees as they move naturally, not buying artificial mobiles, okay? So, and of course, read, those of you who have children, and when you do, choose to read a bedtime story to the child rather than use a screen to put the child to bed, all right? So having them spend more time on the outside. And then as we go up to ages 6 to 10, you may allow them 2 to 3 hours maximum per day. 2 hours maybe on weekends. And the recommendation now for 10 to 17-year-olds is actually up to 3 hours per day. Wow. According to, we heard the statistics yesterday, most young people, and I'm sure older persons too, are on the phones for up to 9 hours per day. 6 hours average per day. And that's still sounding mild, because a lot of times you're on online class, right? And then after class, there's many more hours after that. But see how you can manage to balance a screen time with outside time, with time interacting with others, making friends, and addressing whatever anxiety issues there may be. Additionally, I'm hoping that you will be willing to share the information and encourage others to minimize screen time and use their brain more. Memorize more of those numbers in your contacts. Challenge yourself to learn at least 5 this week. So if you're stranded, you can make a call. And then we hope to promote further research in the Jamaican context. I hope this sparks that conversation and, of course, influencing curriculum development and health policy. Because in Jamaica, our prevalence for dementia is up to 5.9% based on the last study, the last publication that I had access to by Eldermeyer Shearer in 2018. 5.9%. Imagine that increasing 4 to 6-fold by 2060 in our little island. But thank God there are solutions. And of course, this is not exhaustive. These are just a few of what was found in the literature, and I'm sure there are many more to be found to reduce our risk of digital dementia. Thank you.
Digital dementia. Your attention, please. 3 significant thoughts emerged. Impact of technology on cognitive function, prevention strategies, and 3 patient and nursing education implications. Are there any questions for Mrs. Miller? Any questions? Any questions? All right, there's one. Mrs. Miller, you have a question.
I have more so a comment, and that is the studies that have been done, including the one that was presented yesterday, are cross-sectional studies. And the reviews, the systematic reviews, have really tried to make sense of them. So while we must pay attention to the associations that we find, let us bear in mind that there is still a lot more research to be done.
Certainly.
Because there's a correlation, it doesn't mean that there's a causation. Right. But certainly, when you start to see correlation, it could be causation. Mm-hmm. And so, let me give you an example of something that I think would be wise for us before we go out there and start to speak as if we have arrived at something tangible. We need to know, and you mentioned some, that the standard now is about 2 hours or less than 2 hours. After that, it is excess. We actually need to do more studies on the dose-response relationship, and that we have the data. It just needs to be massaged out as to how much
is happening as you get increasing amounts of exposure, because that is one of the more refined ways of looking at seeing if more convincing patterns for causation is there. These are very complex things, and so we also have to adjust for confounders, like amount of exercise and all kinds of other things, different nutritional factors, race, sex, national, all kinds of things. These are things that we need to do, and when we report these things, report them in the context of some of these things, because that would be really nailing it down and being able to convince. Will there be a randomized trial of these things? I don't know if there has been. If there is, we could enlighten me. Or if there are several. I'm still innocent in this area of research. But I just, my alarm bells went off when I looked at it and said, the studies that I'm seeing, a lot of them are not really studies that are really the designs for us to talk about causation. They're more so studies to talk about covariation. So just a little comment there, if you want to add anything to that.
Yes, there were some studies, actually some randomized clinical trials were also done. Some of the studies I didn't focus on because I saw that there were challenges with with how the studies were done. But for some of the meta-analyses and randomized clinical trials, there's still more research to be done, of course. So association for some things, definitely not causation for everything. But because of the strength of the evidence in terms of the correlations, it gives us something to look further on. And of course, as I said, in terms of the implications, opens the door for a lot more research. Thank you for your comment.
I want to ask a question. I don't even know if it's a question or a comment. I know that a lot of time researches are done, and we have a tendency to use America, and it is not to our Jamaica setting. And I have a problem with that because I'm a Jamaican. Mm-hmm. But what you said, as a parent, I can relate to it because I see all of those manifestations in my son about the fact the screen time is adversely affecting him. And one of my peers wanted to ask, how can she reduce her screen times? Because she wants to improve on that. So she was asking if there's any recommendations for that.
For reducing the screen time?
Yes.
Okay, so let me just stick in the first part. In terms of the Jamaican setting. My apologies. Okay, in terms of the Jamaican setting, Dr. Bourne mentioned yesterday that a study was done in terms of social media use in Jamaica. And it is similar to what the World Health Organization and the CDC have found in terms of the 6 hours per day generally among young adults and adults. Based on the standard that has been used for excess screen time being 2 to 3 hours, it was similar to what was found from the CDC in terms of the time frame. And the Jamaican dementia rates I did mention. In terms of reducing screen time, I think I cannot underestimate the power of spending time with God, especially in that first hour on arising, and doing things that will strengthen the frontal lobe, which will improve willpower and your ability to choose. If you can write, do more writing, as I mentioned before. Take more of your notes with your hand, if possible. And spend more time on the outside, if you can. There's a lot more that we need to find out, but these are just a few recommendations that may make a difference.
Thank you for that.
Oh, and for the child, more time outside. Play with the child. Don't have the child trying to get your attention because you're on your phone.
Okay. So teenagers are a different ball game altogether, right?
Teen talk to the teen.
Right, so good afternoon again. So as was mentioned earlier, you're a mother and you have 2 children. What are some strategies that you implemented in your parenting to help them reduce their digital dementia?
Wow. Okay, I will not recommend this for everyone. They got their phones very late.
How late?
Yes, 16. But they are not deformed.
Big up, yes.
They make notes, they're well fed, well formed, yeah, reasoning, and they will make awesome notes. That's what I did. This is not research. This is just in my family.
And it works.
They got the phones late. And we played a lot, and we gave them blocks to play with. So they had to build like the sanctuary, the earthly sanctuary with blocks. They did that. So they didn't have time for... So there are days they can leave their phones at home and not be dying, even now.
Thank you.
We'll take one more in this section and then we'll move on.
This is just a comment to the young lady that was asking about how to decrease screen time with your child or something to that effect. I was reading something recently where a gentleman said, have an allocated time frame to spend with your child. If it's 20 minutes, you spend that time, phone to the side, with your child. If your child wants to go outside and play, go out with them.
Yes.
If they want to sit and do something, don't correct them because you think the technique was wrong. Just stay with them. Spend time with them. And that helps them to know that you value being with them. You value that time. My sons, they're not here. Or they'll probably miss me. My sons, and I still enjoy traveling with me. They're almost 22. We go on vacation. We hang out. Because I invested that time with them when they were younger. And so they appreciate that, and they continue to appreciate spending time with me and just doing things. So block that time out and spend it with them. It's important.
Thank you so much. And I would just want to put a punch in again for health professionals, for healthy screens. You can check them out. Quite a bit of resources there. It would take too much time to share what they have to say, but check it out. Thank you.
We have come to the penultimate presentation in today's nursing symposium. Title is Diet, Lifestyle and Cancer Health Disparities. Is there a connection? Dr. Carlos A. Cassiano, a pioneer in microbiology and health disparities. Ailing from the vibrant shores of Puerto Rico, Dr. Carlos A. Cassiano embarked on his academic journey at the University of Puerto Rico, Rio Pedras, where he laid a solid foundation in biology. He then soared to new heights, earning his Doctor of Philosophy degree in microbiology from the prestigious University of California at Davis. Before he joined the esteemed faculty at Loma Linda, LLU, School of Medicine in 1997, Dr. Cassiano honed his expertise through a postdoctoral fellowship in clinical immunology at the Scripps Research Institute in San Diego. At LLU, he has steered a groundbreaking research program funded by the National Institute of Health. Delving into the intricate dance between autoimmunity and cancer, his pioneering studies on autoantibody responses to tumor-associated antigen among diverse prostate cancer patient populations have illuminated the complex landscape of tumor immunobiology, resistance to chemotherapy, and the disparities in cancer health outcomes. Currently, Dr. Cassiano wears multiple hats as the Associate Director of the LLU Center for Health Disparities and Molecular Medicine. He also serves as the Associate Program Director of the LLU NIH Initiatives for Maximizing Student Development. Since its inception in 2001, this NIH-funded training program has been a beacon of hope for countless doctoral students in the School of Medicine's basic science graduate programs. Through his unwavering dedication, Dr. Cassiano has attracted over $30 million in major NIH fund granting to LLU, where as principal investigator or co-investigator, his scholarly contributions are impressive, boasting over 100 scientific papers and book chapters alongside more than 130 scientific abstracts showcased at national and international conferences. Dr. Cassiano is also a devoted mentor, nurturing over 80 young scientists ranging from high school students to postdoctoral researchers in his lab. He relishes the opportunity to enlighten medical and graduate students on the fascinating intricacies of immunology and cell biology. As a founding member of the LLU Center for Health Disparities and Molecular Medicine, Dr. Cassiano has served as Associate Director since 2006. He is a vital member of the International Advisory Committee for the Dresden Symposium on Autoantibodies in Germany and the American Association for Cancer Research, further expanding its influence on a global scale. Dr. Cassiano's remarkable contributions have not gone unnoticed. He has received several prestigious awards, including the LLU Carroll Small Faculty Development Award, the LLU Hispanic Alumni Community Service Award, the AACR Minorities in Cancer Research Award, the LLU School of Medicine Distinguished Service Award, and the LLU School of Medicine's Mentor of the Year Award. In his personal life, Dr. Cassiano shares his journey with wife, Jelly, and is the proud father of Doctors Carlos and Ariana Cassiano, Washington, fostering a legacy of excellence in academia and research. Ladies and gentlemen, it is my absolute delight to present to you Dr. Cassiano.
Thank you so much for the kind invitation. I know it's lunchtime, and I'm going to talk a little bit about diet and lifestyle, but bear with me, actually intermittent fasting is good for all of us. So let's do some fasting now. I'm again very grateful for this invitation that was extended to me by my friend and our NCU president, Dr. Lincoln Edward, and also Dr. Frankson. I'm very happy to be here. As I said yesterday, this is my third time in Jamaica, my second time here at NCU, and it's always a pleasure to come here because it reminds me of my homeland of Puerto Rico. So yesterday I talked about prostate cancer disparities and some of the research going on in my lab. Today I'm going to talk about the interplay between diet, lifestyle, and cancer health disparities. And the question is there is a connection between this? This is my presentation outline. I'm going to talk a little bit about diet, lifestyle, cancer, then how those influence cancer disparities. I'm going to delve a little bit into the molecular mechanisms by which diet and lifestyle impacts cancer progression. And then at the end, I'll discuss some of the interventions that we're doing at Loma Linda to address these disparities. Yesterday, I showed this map of the world showing that prostate cancer is the second most common cancer in the world after lung cancer. Lung cancer is in blue, prostate cancer is in green. And I mentioned yesterday that prostate cancer is the incidence and mortality are very high in the Caribbean region, also in sub-Saharan Africa, and is associated, has been associated for centuries with the transatlantic slave trade. So all those countries that received slaves from sub-Saharan Africa and West Africa, they have high incidence and high mortality of prostate cancer, suggesting that there are genetic factors influencing that incidence and mortality. But as I showed yesterday, it's not only genetics, it's not only biology, there are multiple factors that are associated with this high incidence and mortality of prostate cancer. But the same applies to breast cancer. So you can see here this map, everything that you see pink, that's high incidence and high mortality of breast cancer. And the mortality of breast cancer is very high in the Caribbean. Actually, it's the fourth highest mortality worldwide. And so you have first breast cancer as the highest mortality associated cancer in the world. Then you have cervical cancer, that's the orange one, and lung cancer in blue. Now let's talk about breast cancer in Jamaica. And this study from Kingston Public Hospital came out a couple of years ago. And this paper showed that the most common breast cancer subtypes in Jamaica are the luminal A and the TNBC, which is triple negative breast cancer. And you can see in the graph that the bars in blue, those are luminal cancer, A. These cancers are estrogen receptor positive, progesterone receptor positive, and HER2 neu positive. That means that they are treatable. There are treatments for these cancers by blocking the activity of some of these receptors. But the second most common breast cancer here in Jamaica is the triple negative breast cancer, the TNBC. You can see that in the graph in the brown columns. Now, TNBC is a problem because it is very difficult to treat it. It's the most aggressive form of breast cancer. In the United States, white women have the highest incidence of breast cancer. And black women don't have such a high incidence of breast cancer. But when you look at the mortality, black women have the highest incidence of mortality. I mean, the highest incidence, of mortality. So you have black women having low incidence of breast cancer, high incidence of mortality, precisely because they're more prone to develop triple negative breast cancer. Another important aspect of this study was that the average age for primary invasive breast cancer in Jamaica is 54 years, compared to 62 years in a black woman in the United States and 63 years for white women. And more than that, the study also uncovered that 1 in 3 Jamaican women are diagnosed with breast cancer before age 50. So the study concluded that there is a need to aggressively implement nationally screening and treatment. Let me try to synchronize my computer with right here, since we need to replace the battery on this. Okay, I'm sorry that I didn't synchronize my computer with the screen. So the study concluded that there is a need to aggressively implement nationally screening and treatment protocols based on data from Jamaica. Because sometimes what we do is we use data from the United States, but that data may not apply to Jamaica. So it's very critical to implement protocols for a screening of breast cancer and treatment of breast cancer here in Jamaica. Now, breast cancer is driven by the interplay between different factors that determine these disparities between white women and black women, and also the outcomes. There are extrinsic factors, like environmental, lifestyle-related factors, but there are also intrinsic factors, including germline mutations, including changes in epigenetics, in the modification of the DNA. There are differences in the host. Every person is different. There are differences in how the tumor progresses and the characteristics of those tumors. And all those lead to differences in outcome. Now, yesterday, I presented this picture in the context of prostate cancer. And as we can see here, the increased risk of cancer is associated with the interplay between many different factors. So we cannot say that genetics or biology drives breast cancer or prostate cancer. We cannot say that lack of access to healthcare drives the aggressiveness of cancer. We have to bring together all these factors: access to healthcare, low socioeconomic status, lifestyle, genetics, biology, psychosocial stress. I talked yesterday about how psychosocial stress leads to increased activity of glucocorticoid receptor, how that activates genes that are associated with resistance to therapy. And there are also environmental factors. So when all these factors combine, then we have higher tumor aggressiveness, particularly affecting minority populations, because minority populations are the ones that usually have the lower access to healthcare, lower socioeconomics, and because of that, their lifestyle is impacted. Now, we all know that diet plays a very important role in cancer prevention. A diet that is very rich in vegetables and fruits that have antioxidants, particularly fruits of many different colors, vegetables of many different colors, also grains, and particularly whole grains, fiber. That diet is relatively protective. Now, I hear some people that say, well, my uncle was a vegetarian all his life and had an excellent diet and did a lot of exercise, never smoked, and had lung cancer. And that's because sometimes there are mutations that are so powerful that they will drive cancer regardless of the diet and the lifestyle, although the diet and the lifestyle help delay the appearance of those cancer types. You have also heard about the importance of lifestyle in cancer. And we need to start doing changes in our lifestyle so that we can delay or prevent completely the appearance of cancer. And that includes, of course, avoid smoking, that we don't do as Seventh-day Adventists, staying fit, eating healthy, using sunscreen to prevent damaging UV light, limiting or abstaining completely from alcohol, getting vaccinated, particularly for HPV virus, which is associated with cervical cancer. So there's a lot of lifestyle changes that we can do, particularly staying fit, avoiding obese and avoiding damaging diets. Now, these are the cancers that are most impacted by diet and lifestyle factors. Prostate cancer is impacted by obesity, low consumption of fruits and vegetables. Dairy products, actually there is an association between high consumption of dairy products and prostate cancer, and also vitamin D deficiency. Breast cancer, obesity, alcohol, low soybean isoflavone consumption, vitamin D deficiency. Colorectal cancer, obesity, alcohol, smoking, and so forth and so on, and vitamin D deficiency. Lung cancer, of course, smoking. Then liver cancer, alcohol, aflatoxin, hepatitis B and C infection, no coffee consumption. And you're going to tell me, wait a second, where is this coming from? Actually, for liver cancer, there has been an association between the lack of coffee consumption, because liver cancer is predominant in Asian populations that drink tea and not coffee. And you said, but how about caffeine in the tea? We're not talking about caffeine. The coffee, whether it's decaffeinated or caffeinated, has a lot of antioxidants. And a lot of studies have shown that 1 cup of coffee per day, even if it is decaffeinated, can give you a lot of antioxidants that are anti-cancer, particularly against liver cancer. Then stomach cancer, high consumption of salted foods, like salt-preserved fish. I'm not talking about cod fish, because I like cod fish, and we all eat cod fish here, but there are countries in Asia where they preserve the fish in very high levels of salt, and they consume that every day, and that is associated with stomach cancer, and of course, Helicobacter pylori infection and low consumption of fruits and vegetables. Esophageal cancer, obesity, alcohol, smoking, low consumption of fruits and vegetables. Oral cancers, HPV infection, high consumption of salty foods, low consumption of fruits and vegetables. And cervical cancer, HPV infection, and lack of vaccination. So there were some common themes here: obesity, low consumption of fruits and vegetables, smoking, alcohol, drinking, and vitamin D deficiency. So what we see is that our diet and our lifestyle can impact many of these cancers. Now, there are non-modifiable risk factors. These are things that you are born with and you cannot modify. Genetic predisposition, age, race, family history, familial obesity, although you can try to stay fit as much as possible, but if you have familial obesity or susceptibility genes, it's very hard to modify those factors. But then you have other risk factors that you can modify: diet, lifestyle, obesity, the microbiota, socioeconomic factors, inflammation, environmental pollutants, metals, and chemical exposure. Now, I'm going to discuss 3 factors that are associated with lifestyle and diet that are emerging in the cancer literature that molecularly may impact whether cancer develops or not, or whether the cancer develops in a very aggressive way. And these are modifiable factors that we can change through our changes in our diet and lifestyle. I don't know if you know that there is a link between vitamin D deficiency and cancer disparities. Actually, African Americans tend to have more vitamin D deficiency compared to white Americans. That's in the United States and also in Europe. I don't know here in Jamaica, because this this deficiency is associated with low exposure to sunlight. But in the United States, the African American population, and you can see here in people that are under 25 years old, 17% of them have a very serious vitamin D deficiency. In the age range of 25 to 50, 58% of the population have deficiency. Then if you look at age ranges of 50 to 75, there might be some insufficient vitamin D, particularly in the African American populations. Why is this associated with cancer disparities? Because vitamin D is critical to fight cancer. The version of vitamin D that we have in our bodies when we get exposure to sunlight or supplements is called calcitriol. And calcitriol, once it goes inside the cell, it binds its receptor called the vitamin D receptor. They go to the nucleus and they modulate gene expression. By modulating gene expression, what they do is that they suppress genes that are associated with tumor cell proliferation. They suppress genes that are associated with inflammation, invasion of tumors, metastasis of tumors, and angiogenesis. But vitamin D induces apoptosis of cancer cells and induces the differentiation of cells so that they don't become tumorigenic. So vitamin D consumption is extremely important for cancer fighting. Let me talk about the second factor that is emerging in the literature on molecular mechanisms of cancer disparities. And these are advanced glycation and age products, primarily caused by glycosylation of proteins or sugar binding to proteins. All of us like sugar. All of us like sweets. But when carbohydrates and sugar are consumed at a very high rate, particularly if it involves frying, if it involves cooking at high temperature, then we have problems because those sugars bind to proteins, bind to lipids, glycosylate those proteins and lipids. Those glycated proteins form what is called H metabolites, advanced glycation and metabolites. They basically disperse through our bodies and they cause a lot of problems, including induction of mechanisms that might be associated with cancer progression. So particularly minority populations or poor populations that are plagued with a lot of social factors that prevent them from having a more balanced diet, having a more diverse diet. What happens is that these populations tend to eat foods that are rich in fat and carbohydrates and sugar, which leads to the formation of these ages. Let me give you an example. How many of you like carrots? Carrots. Okay. My friend, Dr. Turner from Virginia Common University, what he has done is he has been able to determine the number of age units in different foods. And carrots have 5 age units, which is pretty good. If you eat a piece of chicken, boiled or veggie meat, even soy veggie meat, about 500 to 1,000 units of age. People who eat bacon for breakfast, particularly in the United States, with 2 strips of bacon, they're eating 90,000 units of ages. Imagine. So when you have these ages that interplay with low socioeconomics, where the population doesn't have enough financial means to eat healthy, or they live in neighborhoods that are so violent that they cannot do exercise outside, or they have different other comorbidities that prevent them from moving, prevent them from having a healthy lifestyle. The consumption of ages eventually leads to changes in our body that promote the initiation and progression of cancer. And the last molecular mechanism I would like to discuss is the microbiome. We have thousands of species of microbes and viruses living in our body, particularly in our guts. And a healthy diet, particularly a diet that is balanced and that has a lot of variation and diversity, promotes a healthy microbiome in our guts. So the more variety of food you eat, the better it's going to be your gut microbiome. However, if you look at how your gut microbiome interacts with other systems in the body, there is literature emerging that the brain, the immune system, and the gut microbiome talk to each other in order to promote a healthy functioning of the body. But when our diet and our lifestyle is not very healthy, that's going to change the composition of our gut microbiome. And then what is going to happen is that interplay, that interconnectivity, that communication between the gut microbiome, the immune system, and the brain are not going to be optimal. Then you have all the mechanisms in place for the initiation of cancer. Because some of the bad microbes that we don't want to have in the microbiome, they cause cancer, or they initiate inflammation, or they initiate molecular mechanisms that are associated with cancer. So here you can see that the microbiome is associated with cancer progression. It could be associated with cancer prevention if it is a healthy microbiome, but if it is an unhealthy microbiome, it's associated with cancer progression. If it is a healthy microbiome, it's associated with good immune modulation. If not, it's associated with inflammation that leads to cancer progression. Also, a healthy microbiome can modulate positively our metabolism, but an unhealthy microbiome cannot do that. And finally, the microbiome can also influence how we respond to therapy. So keep in mind, for those of you who are planning to migrate someday to the United States, to the UK, or Australia, or other country, that migration to the United States or other developed countries lowers the diversity of your gut microbiome. By doing that, it increases cancer incidence. Now, if you look at what is happening with different populations that migrate to the United States, they show increased risk of prostate cancer. Because especially if they're coming from Asia, where there is a lot of fruit and vegetable consumption. But they come to the United States, they adopt the Western diet, which is not a very healthy diet. This is the opposite of the Western diet. This is what they have in other places. This is what we may have here in Jamaica and in some parts of Puerto Rico. A very healthy, very balanced diet. But when those immigrants go to the United States or to Europe or other developed countries, they change their diet and they adopt this pro-inflammatory, pro-cancer diet. leading to an increased incidence of prostate cancer among Asian immigrants and other immigrants that come from the islands into the United States. So I think my time is over. I'm going to wind down here. But the question is, what do we do? Well, let's talk to our community. Let's talk about healthy living. Let's raise awareness about how diet and lifestyle can lead to increased cancer incidence. Let's talk about how people who had cancer and survived cancer decided to be outspoken about their cancer, decided to educate the community about cancer, and they made a difference. And finally, at Loma Linda University, we have a project called Project Change, changing health and adult men with new and great experiences. And what we do is that we go to the community. The community invited us. The community said, we need you guys to talk about prostate cancer or breast cancer or diabetes. We go to the community, we have health fairs, and these health fairs involve a lot of health professionals from Loma Linda, particularly nurses. Without the nurses, we cannot conduct these health fairs. And in these health fairs, we provide different services. We do PSA testing. We do prostate cancer education. We do diabetes screening. We do blood pressure screening. We educate the men not only about prostate cancer, but about diet, about lifestyle changes. And we have done this already in many different places in California, but we did one in Brooklyn. Why Brooklyn? Because Brooklyn has a high population of Jamaicans and other Afro-Caribbeans, and we wanted to compare. And in these health fairs, not only we provide these services, but we also collect surveys that inform us about the health of these communities. And we have learned a lot. We have learned that there are differences in cultural beliefs towards screening of prostate cancer and other cancers. We have learned that there are cultural beliefs about going to the doctor or not going to the doctor. Cultural beliefs about diet. In some cultures in the Caribbean and also in West Africa, people think that by drinking teas, they will prevent cancer. In other cultures, there is a fatalism, and the belief is, I'm going to get cancer anyway, so why bother? This belief that you're going to die anyway. So these are differences that we have encountered, and there are several papers that you can look up. If you look at Cassiano, CA, and prostate cancer disparities, there are several papers that we have published in the last 4 years with those conclusions. So what can we do to prevent cancer? Let's try to live a healthy lifestyle, a lifestyle that involves having a healthy diet in moderation, regular exercise, regular checkups, cancer screening, healthy relationships, strong spiritual life. And with that, I'll leave to you the task, the mission of educating your community about how modifying diet and lifestyle can help prevent cancer and prevent cancer aggressiveness, or if the cancer is going to come anyway because of non-modifiable factors, at least to delay the onset of that cancer. Thank you very much.
A very interesting presentation from Dr. Cassiano, and for me, 5 pivotal points emerged. One, and I hope the ladies were listening carefully, there is a decrease in the incidence but an increase in death in breast cancer among black women. One. Two, diet and lifestyle. It suggested that diet and lifestyle both have an impact on cancer development. Three, he further suggested that socioeconomic factors affect health outcomes. Four, he gave some nutritional intervention strategies. And five, population health considerations. At this time, I'll entertain about 2 questions for Dr. Cassiano. And if they are short, we'll take 3. The questions are short.
Cassiano, for that excellent presentation, as usual. Could you just say a little more about breast cancer in men and also the relationship between oral sex and oral cancer?
Yeah. Breast cancer in men, it does happen. That study that I mentioned about Jamaica showed that 3% of all breast cancers in Jamaica happen in men. In men, tends to be the breast cancer less aggressive than in women. The triple negative breast cancer doesn't happen. Typically, in men is a more treatable man, but you can die as a man of breast cancer. In terms of oral cancer, there is a relationship between oral sex and oral cancer due to infection with human papilloma virus. So if one of the persons is having the oral sex is infected with human papilloma virus, the other person can get infected and develop oral cancer. There is evidence for that. It also happened in relationships between men that have sex with men. That also happens. Human papilloma virus the incidence is increasing in the Caribbean. I was in Puerto Rico about a month ago in a conference where they presented data indicating that HPV is now becoming the most common cancer among Puerto Rican women. And it's typically related to lack of vaccination. So the uptake of the HPV vaccine in Puerto Rico is good, but it's not as good as it should be. So there are efforts across the island to vaccinate not only women, but also male children to lower the incidence and the mortality from HPV. I'll leave it there because it's a topic where we can spend a lot of time talking about it, but live a healthy life in everything that you do, not only in diet, lifestyle, but also in your relationships. Try to be as healthy as possible so that you can prevent some of these infection-related cancers like HPV-induced cervical cancer or oral cancer. Thank you very much.
So we have come to the final presentation in section 3 and for Research Symposium 2025. Title that we'll be looking at, is a recipe for mental wellness in unprecedented times, implications for patient care delivery. Presenter Dr. Martin Frankson, a dedicated pioneer in public health and education. Born in the vibrant heart of Kingston, Jamaica, Dr. Frankson has journeyed through all the parishes of eastern Jamaica, now calling the serene landscapes of Manchester, Mandeville to be specific, his home. His educational path began at St. Mary's High and Kingston College, where he laid the groundwork for a remarkable career in medicine. As a proud graduate of the University of the West Indies and Loma Linda University of Public Health, Dr. Frankson embarked on a mission to enhance health and well-being in his community. In the late 1970s and early 80s, Dr. Frankson served as a medical officer for the government of Jamaica, where he made significant contributions to public health. In 1980-81, he took on the role of Director of Health and Temperance Department with the then West Indies Union Conference of Seventh-day Adventists, demonstrating his commitment to holistic health. His career further expanded as he co-managed a USAID-funded primary healthcare project with the Adventist Development and Relief Agency in Trenchtown. Dr. Frankson's diverse expertise spans various roles, including general practitioner, public health program evaluator, and a manager in both Jamaica and the United States. From 2004 to 2006, he proudly served as the Chief Medical Officer for the government of the Turks and Caicos Islands, navigating the complexities of leadership. Dr. Frankson returned to academia and made his mark as a health research scientist at the University of the West Indies, where he lectured in epidemiology, biostatistics, community health, medical humanities, which includes ethics, professionalism, and the history of medicine. Faithfully committed to his beliefs, Dr. Frankson actively participates in the Seventh-day Adventist Church, currently serving at the Northern Caribbean University Campus Church here in Mandeville. His scholarly contribution includes co-authoring over 40 scientific publications, further cementing his legacy in public health research. As of mid-August 2023, Dr. Frankson has taken on new roles as the campus physician and the Director of Research and Statistics here at Northern Caribbean University. He also presides as the President of the Bioethics Society of the English-speaking Caribbean and chairs the National Mirror Committee, volunteering with the Bureau of Standards Jamaica. Notably, he is the founding instructor and the consultant for the Advent Health Volunteers Association in Jamaica, fostering community engagement in health initiatives. In his personal life, Dr. Frankson is happily married to Myris Yvette Frankson, and they share a son, Gregory, who resides in Tampa, Florida. Through his unwavering dedication to health, education, and community service, Dr. Frankson continues to inspire those around him, embodying the spirit of service and scholarship. Ladies and gentlemen, I present to you Dr. Martin Frankson.
Hello, everyone. It's my pleasure to present Recipes for Achieving Mental Wellness in Unprecedented Times, Implications for Patient Care Delivery. And I guess it will be, beautiful. Well, I have no conflict of interests that I know of, and I'm highly interested in nurturing ethical research and harvesting successful lifeways. Here's the recipe. Number 1, trustful thankfulness. If there's a lecture you should have missed, it's not this one. This one is going to make you so well, it's going to be amazing. trustful thankfulness is a major theme in religious texts. Philippians 4:6 says, "Be anxious for nothing, but in everything by prayer and supplication with thanksgiving, let your requests be made known to God." This is powerful as an ingredient, as a recipe for successful lifeways when you couple it with steadfastness. There we go. Joy, being merry to the core. The joy of the Lord is my strength, Nehemiah tells us. Joy is really a choice rather than an emotional state. It is an elected mindset that finds gratitude and merriment. As we see in Proverbs, a merry heart doeth good like a medicine. And you couple that with thankfulness in God, your cooking of a successful lifeway just starts to get tasty. Rejoice, I say, in the Lord always, Philippians 4 verse 4 tells us. In fact, folks, if there's a disaster, if there's anything wrong, etc., you compare the WHO mental health first aid recommendations with the chapter of Philippians 4, and Philippians chapter 4 is that and more. Even in difficult circumstances, rejoice in the Lord. Note, I'm not calling here for perpetual ecstasy. Sometimes you can rejoice silently, like I'm doing right now. Make sure that there is peace. I don't know what's happening here, but I'm still rejoicing in the Lord. Peace. Great peace have they that love God's law. That's a true loving guide. God's law is not by force. It's by choice to you. Consequences one way, consequences the other way if you obey it. I want to tell you something, that you have great peace if you love excellence as well. And one of the great things we pointed out earlier on in the introduction was that excellence and research, they're married. Stress management is key. Okay, I can't spell. Preventatively manage chronic stress. We're not talking about the stress of a short-term nature. A little good stress is wonderful. Sometimes it keeps you focused, etc. But if you're getting everyday chronic stress, you're building up what we call a bad allostatic load. You are going to find that it impacts your body in many ways, including your mental health in significant ways. And we need to find ways to cope. We always try to find ways to cope, but we need to find ways to cope that are successful. Here are some of the techniques then. Practice relaxation techniques. I want you to do something for me quickly. Tighten up your toes like this. Everybody? Okay, tighten up your feet now along with your toes. Okay, tighten up your ankles. Okay, tighten up your calves. All of those. Tighten up your knees. Tighten up your thighs. Tighten up your hips. Right through to the tight tush there. Tighten up your back, tighten up your tummy. Let's feel the six-pack. 1, 2, I only have 2. Tighten up your chest, tighten up your arms, your legs, etc. Right up to your neck. Tighten up your face, tighten up your head. Okay, start relaxing your head now. Start relaxing your face, start relaxing your neck, start relaxing your shoulders, start relaxing your chest, start relaxing your back and your abdomen. Start relaxing your hip, start relaxing your thighs, start relaxing your knees, going down to the ankle, relax the feet, relax the toes. Do you notice how there's a wonderful, wonderful treatment right there? You could do that in an exam when the questions are hard. You just take a break, bam, do that in less than 1 minute, and I just did it. and your brain starts to function. All 3 pounds, 1.3 to 1.4 kilograms that are there in the skull. And you're not made to function alone. So mix in a nice, constant dose of fervent prayer without ceasing. You don't have to be kneeling down. Prayer with faith, that works. That's what we're told in Peter's admonition to us. Enjoy nature, music, being in your body rhythm. It helps you to find a certain resetting of all of your functions that is just healthy for you. Check on your pulse, check on your circadian rhythms. Make sure that there's a regularity to these important things in your life, and we will see a lot of that helping us as we press on. Nutrition. Let's do mindfulness and self-reflection. Be non-judgmental when you are paying attention in meditation. Doing that reduces stress and improves your emotional awareness. Done through meditation and reflecting on one's thoughts and feelings, identifying one's values and goals, that is what we call mindful meditation. Not meditation where you contemplate what your friend just did you that was hurtful. Forgive them. Let it go. Coming apart and just noticing your body, how it breathes, and noticing the pattern of breathing, whether it's shallow or not, etc. And making sure that you do that along with the other things that we've just mentioned, the joy, etc. Now, nutrition, everybody agrees? That's an important one? Just about now? Eating healthily balanced diets is just wonderful, that what they will do to benefit the brain and everywhere in our bodies. Consume plenty of all the things you have been told a while ago. But I want to mention N3 or omega-3 fatty acid foods, like certain kinds of fish, like salmon, but your nuts, your almonds, your walnuts, etc. Those are things that are going to be helping you to reduce stress. And did you notice dark chocolate is on the list? Because it doesn't have much sugar, but it has lots of these things, and they go towards a wonderful effect on our brains. Limit processed foods, sugars, etc., alcohol, tobacco, and other drug use. Avoid those. Be active. Exercise. Physical exercise releases endorphins. Endorphins have, 1, a mood-boosting effect, and 2, it can reduce distress and anxiety. Plan for and do 30 or more minutes of moderate intensity exercise 4 to 6 days per week consistently. And that's different from moving up and down in the office, etc. That must be your extra treat to yourself. Moderate ones that I'm thinking of would include bike riding, walking, running, jogging, swimming, cycling, certain games that we have made provisions for you out here on and other places where you live, and so forth. You notice what those things are going to do? Those things are actually going to really make your life interesting. Really make your life interesting. Make sure that with all of that, you make time for sleep, 7 to 8 hours. It helps to prevent depression, and it helps to improve concentration. When I come home from work, I have put in a lot of work. I get up very early in the mornings, and by the time I reach to that place where I am, I just sleep for 2 to 3 hours. And I get up, and if I need to write the president a letter at 1 o'clock in the morning, he's getting that letter at 1 in the morning. He'll read it by 1 p.m. the next day. And life goes on beautifully. When I need to study my Bible, I never study my Bible when I'm tired. It's too important to me. The words that are coming from it are life-giving. I don't want to be glossing over anything. And I'm this kind of person who, if I need to get something out of a chapter when I'm tired, on a paragraph that I have not understood something, I will get stuck on that for an hour just reading over the chapter, even though I'm not getting anything out of it, trying to find what the chapter was saying. I'm like that, obsessive that way. So what I do is I don't even bother to start the chapter when I'm tired. I go and sleep. When I get up, I read it. In one read, I got the context and everything of it, and I'm moving along. Make sure that your bedtime routine is one that goes into a relaxation. Make it dark during the nights, quiet rooms, avoid screen times and so forth. We've been well schooled in that. As to light, make sure that you get plenty of sunlight in moderation, especially the midday sun. You need the midday sun because what it does is it goes right through your body with the infrared lights. And infrared lights stimulates your mitochondria, and among other things that your mitochondria produces are antioxidants such as melatonin. That melatonin is not melatonin that you use so much like you use melatonin from your pineal gland in your brain. That melatonin helps to improve your immune system in its metabolic pathway. But you do need to sleep at nights. And the melatonin that is produced when the lights are off goes now toward helping you to have the right length of sleep. That also is just wonderful for many, many functions within our bodies. So, I've left many other bits of information there on some of the biochemical things that all of that will do. Let us press on, but just notice that the other thing that all of that does is that really helps us to produce the right amount of serotonin, and the whole serotonergic system is very important for helping to prevent mania. That's what people used to call madness. Depression, the opposite, but still a mental disorder. Sadness, even things like schizophrenia or other mood-related diseases, anxiety-related diseases, and ADHD, among other things. So, just getting light in its right ratios, along with sleep and joy and nutrition and so forth, you're actually going to be preventing mental illnesses. Moving right along, we're almost there. Make sure that you learned from Genesis that we were not meant to be alone. It is not good for us. And this has mental implications. Can you imagine Adam by himself walking around all day, nobody to talk to? Well, now you understand why I stop you so many times on the road and talk to you. I just want to stay mentally well, but I want you to be mentally well too. Mental implications, because we need to be connecting with each other, we need to be communicating. You need to be encoding information and transmitting it over to me, and I need to be receiving it and decoding it so that I can build patterns and we can connect, and together we can be stronger. And you know what Proverbs says, that a cord that is 3 strands is much stronger than a cord that is just one strand and more easily broken. So, what you need to do then is to make time that you do that with God first, and also with his people that he has assembled and called the saints. Make sure you don't miss these services, the spiritual services of the week. Come and assemble together. Wonderful things are shared there that just build you up and build up your hope, build up your faith. And then you go and do the same thing with your loved ones. And then you go and do the same thing with others as you join social groups. Volunteerism is key. And the more you volunteer, temperately of course, is the more you actually see things being done in your society to help to make a difference. And one of the things that is important for us is to see our societies improving. If I am at NCU for so many years, one of the markers I'm going to make is whether when I'm here at NCU, research week and research activity has been improving. If not, I'm going to be depressed. So everybody, please get your research projects going. Help me to prevent my depression. Make sure you have good personalized care. Spiritual loved ones, God especially, amidst all. But also remember your body, mind, and the social aspects together function together. A big word is biopsychosocially. And we need, therefore, to look in a holistic way for people who can give us care and for how we give ourselves care. Don't just try to build muscles. While you're building muscles, build relationships and also build good mental ways. Calling God's name in vain, waste of time for your mind. Learning to say things without curse words in the sentences, healthy thing for your mind. Look at your intellectual improvement. The smarter you are, the healthier you are, usually, as a group in society, especially if you do all the other the things that are recommended, because smart people usually do that. And by the way, there are studies that show that people who read more have less illness and live longer. Literacy is associated with good longevity. One of the sweetest books that I am going through now again is Great Controversy. Read that book and you'll see that we're living in interesting times, not just now, but ever since the devil has messed up this earth. And they've been very interesting in some really shocking ways in the past. You will realize that this is not the only interesting time in which we live. Your professionalism must also be paid attention to. Etiquette is important. Saying hello, being courteous, treating this other sex with respect, etc. It helps you to feel like you're not just an animal out there like one of those dogs running down and another dog and they fight every minute, but you're courteous and you're kind, etc. You build that along with ethics, which we talked about yesterday, and also with competency, which your teachers talk about every day, among other wonderful things that we have here. Pay attention to your environment. God did not place our first parents out in space. He placed a beautiful environment and then placed them in that environment and integrated them in a way where they were responsible to have dominion, rulership, governance of that place. So, folks, I want to tell you something in closing, and that is this. Philippians 4, verses 6 to 9. Do not be anxious about anything, but in every situation by prayer and petitions, with thanksgiving, present your requests to God. And the peace of God, which transcends all understanding, will guard your hearts and your minds in Christ Jesus. That's the New International Version. Finally, brothers and sisters, I like that. The King James only says brothers. Whatsoever is true. And there comes research helping us to find out what is true. Whatsoever is noble, whatsoever is right, whatever is pure, whatever is lovely, whatever is admirable. If anything is excellent or praiseworthy, think about such things. Whatever you have learned or received or heard from me or seen in me, put it into practice. and the peace of God will be with you. Did you just notice? We start out with whatsoever is true, and we end up with whatsoever is praiseworthy. Truth leads to praise. God bless you. Cook up a storm.
As I have done for the previous presentations, I will do for this one. The key themes emerging: adaptive care strategies, poor crisis management, and the healthcare provider resilience. Are there any questions for Dr. Frankson? Any questions? Okay. Collectively, I'd like to thank the three presenters for this final section, Mrs. Miller, Dr. Cassiano, and Dr. Frankson, for their excellent presentations on contemporary healthcare challenges. Respected colleagues and friends, both in-house and online, our academic odyssey has drawn to its close. We stand enriched by the cascade of knowledge that has flowed through these halls today. Like master artists adding brushstrokes to a collective masterpiece, each presenter has contributed to the grand canvas of nursing and healthcare knowledge and understanding. The persistent pursuit of knowledge displayed here today reminds us that nursing and healthcare research, like the phoenix rising from its ashes, continuously renews and reinvents itself. As you depart today, carry with you not just the knowledge shared, but the spirit of inquiry that has permeated these proceedings. May these presentations serve as stepping stones for future investigations, and may the connections forged here today grow into collaborative bridges tomorrow. Ladies and gentlemen, I now invite Mrs. Farah Adrian Forrest to bring the vote of thanks as we bring the curtains down, after which we will sing the alma mater.
Mr. President of the Northern Caribbean University, Dr. Lincoln Edwards, Vice President of the Academic Administration, Dr. Nanibala Paul, Director of Research and Statistics, Dr. Anthony Frankson, Dean of the College of Natural and Applied Sciences, Allied Health and Nursing, Dr. Vincent Wright, Director of the Department of Nursing, Mrs. Juliette Poyser, faculty and staff of the Nursing Department and the Northern Caribbean University, dear sophomores of the Nursing Department, dear freshmen of the Nursing Department, students from other colleges of the Northern Caribbean University, most esteemed participants. It is a great responsibility, but an honorable privilege to present the vote of thanks for this special event. Therefore, on behalf of the administration, faculty, and students of the Department of Nursing of the Northern Caribbean University, I want to start by expressing a deepest appreciation to our keynote speaker of the day, Dr. Marcia McAllister. Many times, students and even professional nurses tend to be afraid and flee research, like this science does have nothing to do, with our profession. Yes, very often as nurses, we tend to forget that our practice and entire profession is crucially linked to evidence which is grounded in research. Your presentation, or the presentation of Dr. McAllister this morning, reminded us that our nursing care work hand in hand with research, especially ethical and reliable research, and this made up an incredible link that greatly impacts patient outcome, care, and global health, which would be our priority, of course. She strongly and clearly emphasized that whenever this link breaks, the consequences are critical for all stake and shareholders, focusing on infection, for example. She did not only satisfy in seeing the students just listening to her presenting, but she skillfully integrated them in her presentation. So I want to believe that all nursing students here today understood the precious input that Dr. McAllister brought to their academic journey, that they are now becoming sensitized about the importance of research, and they are planning to apply her advice and make use of the tools and meaningful information she provided to perfect their learning. Now, the practice and the quality of care they will be very soon provided to themselves and to fellow brothers and sisters wherever they might call to serve. So may God continue to bless Dr. McAllister in the position she is currently holding, and as she continued to nurture the people of the Lord in the place of care. Mrs. Juliet Poyser, Director of Nursing at the Northern Caribbean University, you are greatly acknowledged for your wonderful remarks and the presentation of the keynote speaker. Your work as a Director of Nursing is tremendous, but may God, the great leader, continue to guide your leadership. And Mrs. Carol Stewartson, you are a nurse instructor and the BLS instructor in the Department of Nursing of the Northern Caribbean University. You are also acknowledged for bringing your kind words of appreciation to the keynote speaker. May God continue to bless you. I must mention also a deep sense of thankfulness to our devotional speaker, Mr. Wessner Forrest, a nurse instructor at the Department of Nursing of the Northern Caribbean University. Do science and God two separate entities which have no relationship at all? Is research man-made and God does not have nothing to do about it? Your meditation, Mr. Forrest, at the beginning of this program help us dive into the true meaning of the scripture. You show us how God is the first and greater researcher. He is actually the one who established the very ethical principles that can truly lead all nursing researchers to bring ethical findings that will influence accurate ethical decision-making to frame quality and ethical practice. You also meticulously emphasize the central need for nursing researchers to be led by the Holy Spirit of God, such as Caleb and Joshua did. This is the only and surely way successful lifeways can be harvested. We have been inspired by the Word of God. May the greatest researcher continue to lead your path. A heartfelt gratitude is extended to Ms. Charis Drummond, Assistant Class Chaplain, Junior Nursing Class of the Department of Nursing, for bringing us up to the Father's throne, because prayer brings us to heaven. And you also invited God, our first and most privileged guest, in this heaven. May God abundantly bless you. On behalf of the nursing department, the privilege is also mine to acknowledge our presenters. Dr. Caroline Nikki McLean, Director of Simulation of Innovation and Assistant Professor at the Northern Caribbean University. We know now that robot and humans seems to start cohabitating in the world nowadays. We cannot deny it. So, as I was saying, that we know now robot and human seems to start cohabitating. We cannot deny it. And virtual robots start to submerge our nursing profession. Then your presentation helped us to understand the issues, the challenges, and the ways that we could approach this matter. It definitely will, your presentation definitely will help our nursing students to start preparing themselves for what to expect throughout their learning journey and their career later. So may God keep and strengthen you as you are reminding us importantly that even though things are transforming today, but the human brain makes robot. And God created the human brain. We continue to acknowledge Mrs. Miller, Jonelle Miller. Of course, the digital world is invading us, and we have few or even nothing we can do to stop that. Yes, a sort of cohabitation is taking place, but robot has its environment and human has its own environment. Although robot will never be a human, but sometimes we tend to think that we can become digital as them, while we are not considering the consequences, because we give them too much of our time, our life, ourself, and we do not notice the short or the mid or the long-term vital consequences that will happen later. Thank you for reminding us about that in your presentation, and may God continue to guide you and raise you as a sentinel for his people in those critical times. Thank you. Yes. We want to acknowledge Dr. Carlos Casiano. Dear Dr. Casiano, work, study, even living in this world consume most of the precious part of our time. And sometimes we tend to forget and even neglect our health. When we are trying to make the effort sometimes to change our lifestyles, especially our nutrition, we don't really know what we are eating, or we don't know how to balance it well. And sometimes we may know, but we cannot afford it. And yet, diseases, especially cancer, seems to be like a plague in our century, threatening our life and destroying our families. Your presentation awoke our concern on that aspect, but also you presented us ways to foster a better lifestyle, especially our nutrition, so we can minimize as much as possible the risk of being affected by these diseases, mainly for us, the Black population. May God continue to bless your ministry. It's a privilege to mention Dr. Morton Anthony Frankson. Primarily, we acknowledge you for the planning of this opportunity you gave us, the department, so that we can have this important event. Research is a vital organ in the body of a university. But also, your presentation on recipe for achieving mental wellness, it's not a skillful mixture of rice and beans, but a required and meticulous combination of important ingredients such as sleep and rest, personalized care, sunlight, social relationship, to name to just these few. And above all, the finest and most precious ingredient is faith in God. We look impassionately forward to test the upcoming recipes you promised us, and we expect that they will not only be a delight in our taste, but also they will help us booster our mental wellness. May God continue to inspire you and your team. Thank you. So, finish. So, we want to also acknowledge our panelists, Dr. Caroline McLean, and the junior and senior nursing students, led by the moderator, Ms. Rojan Miller. An event of this dimension requires also meticulous planning and execution, and a fine eye watching over single details. In that matter, we want to acknowledge Mrs. Joy Braham, professor in the Department of Nursing, Northern Caribbean University, and Mr. Horace Williams, Assistant Director of Nursing and at the Department of Nursing of the University, Northern Caribbean University, sorry. Your consistency and discipline in work, your patience and tremendous courage, and your great desire to reach success have led us to this event point time, and it has greatly contributed to the organization and success of this event. Such leadership, initiative, and patience are critically needed for the advancement of our department. A program with such level would lose its delightful taste without a musical touch to relax our brain and keep us focused on God. Therefore, Hula Green, senior nursing student, the sophomore and the junior nursing students, you are acknowledged for your musical items. May God continue to bless you with wonderful talent to better serve Him. I want to take this opportunity to recognize and extend our most sincere thanks to all administrators of colleges and all faculty and staff from the Northern Caribbean University and perhaps other universities if applicable. We were honored by your presence today. I express my sincerest words of thanks to all of our guest invitees and participants from different destinations who have whether connected online or presential to take part of this program. Your presence enriched the occasion and brought more meaning to the event. My words of appreciation are also extended to all nursing students and other students of this university, to all colleagues and those who contributed in one way or another to the success of this program. Finally, I must acknowledge and thank all those who manage the technical aspects of the program, NCU Media, CCMPR and Special Events Department, the sophomores of the nursing student for their interesting displays. Your incomparable work must, often not seen, significantly contribute to the beauty and success of this event. Administrators, speakers, guests and technicians, students and other participants, once again, the nursing department of the Northern Caribbean University is using my voice to express sincerest grateful words to all of you for being with us. It has been a great pleasure. Thank you very much.